Hello? Oh, okay. Hi.
Thank you.
All right. Congratulations and welcome to the final round. Very proud of you for being here. So I'm going to go ahead. I'm Tyler Matt. I'll be the host for your presentation. Just going to go ahead and recap some of the rules. I'd like to introduce yourself, and then we'll get started. Okay, so just like the first round, you have 15 minutes for your presentation. When you have a 2-minute warning, I'll hold up the sign. And when time has elapsed, I will hold up the stop sign and say time. Following that, 10-minute round for Q&A. Again, same thing with 2-minute warning. Okay. All right. Go ahead and introduce yourselves. Team.
Awesome. My name is Jansen Howard. We are Team G.
I'm Maddie Skinner.
I'm Samia Habib.
All right, excellent. As a reminder, any mention of your university name will be disqualifying. But you may begin when you're ready. I will start the time when you begin.
Awesome. Okay, good afternoon. Thank you everybody for being here today. We are Fast Track Consulting. My name is Jansen Howard.
I'm Maddie Skinner.
And I'm Samia Habib.
And today we're going to take you through how we're going to build a better future for Ochsner Health. Before we begin our journey, it's important to know a little more about Ochsner. Ochsner centralized their PFC in 2018, supporting 28 hospitals in external and internal transfer requests. They currently operate similar to an airport command center in the way that they monitor patient inflows and outflows. They have an average level 2 transfer time of 11 hours and 48 minutes, which is on the upper end of the national average. They accepted 23,287 transfers in 2025, while missing just over 7,000 transfers due to lack of standardization and prioritization. Ochsner has many strengths which we wish to build off of. Some of those strengths include their market share, innovation and technology, which they have received many awards for, and their reputation in the community of the Gulf South. Some areas for improvement could be subjectivity and communication, which in a health system this large makes sense because they have so many hospitals to communicate within. Some areas for opportunity are standardization and objective decision making. Another area is capacity constraints. Ochsner has so many patients that sometimes the hospitals can fill up while other hospitals are open. With this, we'll have technology implementation. Some threats include the big beautiful bill, for-profit and nonprofit competitors, and resistance to change. Our mission at Fast Track Consulting directly enhances Ochsner's mission. Our mission is to elevate Ochsner's performance through standardization, unlocking hidden capacity, and the ability to predict demand so that Ochsner can continue to be a leader in their community and serve their patients in their most vulnerable states. Now I'll pass it off to Maddie so she can take us through our future.
Thank you, Jansen. So as Jansen stated, Ochsner's Patient Flow Center is currently struggling with a lack of standardization and prioritization on which patient gets the next bed. Well, in the future state of the Patient Flow Center, we will ensure that there are standardized operating procedures, objective workflows, and defined roles. One of the largest changes we'll make is how Ochsner views the operations of their Patient Flow Center. While they currently operate similar to an airport command center, we all know the place you're most likely to experience delays and cancellations is within an airport. We will change their model of operations to look more like an F1 pit crew with safety and efficiency at the forefront. With this new operation model, we're hopeful that Ochsner will be able to reduce their level 2 transfer time to 9 hours and 33 minutes, bringing us closer to the lower end of the national average by specifically reducing the time to physician acceptance and the time to bed assignment. With this new model, Ochsner will be able to complete nearly 32,000 transfers by year 3. With a change this large, it is crucial that we have a good change management model. Our team created our own change management model known as SPARE because it perfectly aligns with our F1 pit crew. As pit crews always have a spare tire, our hope is that Ochsner always has a spare bed. This begins with stakeholder engagement. We know that having the right people bought into our plan is crucial for success. We'll then lay out our plan of new operating procedures and staffing models. We'll put this plan into action with our pit crew, we'll reinforce it through an error log, and then we'll be able to enhance operations through an AI predictive model. The stakeholders we've identified for this implementation include direct, indirect, and external stakeholders. Our largest and most important direct stakeholder is our patients. They're directly impacted by the operations of the patient flow center, and we want to provide the highest quality care possible. We also have our PFC staff and leaders. This includes our physicians, our nurses, and our coordinators. They need to be bought into the plan and ready to adapt to the new workflows. Our indirect stakeholders are our hospital administrators and executives. While they don't directly work in the patient flow center, it's crucial that they're brought into our plan so they can assist with implementation and motivate their teams. And lastly, we have our external resources stakeholders. These are our community hospitals and resources. Ochsner currently uses community EMS to transport their patients, so it's important that we maintain that positive relationship with them and they understand our workflows. And our community hospitals, while not a direct part of Ochsner's system, help our patients receive the right care at the right time, closer to home. Our plan will take place over 3 different phases, or as we'll call them, 3 different pit stops. Our first pit stop is standardizing all procedures within the New Orleans Patient Flow Center. We've decided to start with this PFC because it's the largest, most likely to experience delays, and will allow our team to collect the most data. Pit stop 2 is a system-wide rollout to Shreveport and Lafayette, where we'll be able to continue unlocking hidden capacity without any physical expansion. And our last pit stop before the finish line is the implementation of our AI predictive model. I'll now pass it over to Samia to walk us through our plan.
Thank you, Maddie. I'll be going over our standard operating procedures known as SOPs. Our SOP for patient acuity assignment ensures that the PFC team receives standardized acuity information from the moment a transfer is initiated. We created a patient acuity flowchart to help with objective decision-making. We've identified that Ochsner has 2 patient acuity levels, urgent and non-urgent. So getting this right will prevent any misplacement, delays, or internal transfers. And when we can avoid all of that, each bed turns over faster. This effectively creates capacity without needing more rooms. Our bed matching SOP aligns the patient's needs with appropriate bed type. Based on the patient's acuity level and the hospital capacity, they will be routed to the appropriate medical centers. This will reduce internal transfers in the future. Fewer moves means fewer delays, which means faster bed turnover. This also improves patient safety by ensuring that the patient's needs are met immediately upon arrival. Communication is the connector of all decision points. We've identified that while Ochsner has a list of phone numbers on their website, they actually prefer using Epic for transfer requests. Our SOP uses Epic as a standardized communication platform for non-urgent transfers while keeping phone calls for those urgent ones. When communication runs smoother, patients move faster, and this effectively increases capacity hospital-wide. Now, even the best processes encounter barriers such as patient regression or natural disasters. Our escalation SOP ensures rapid resolution by clearly defining when to escalate, who to escalate to, and how those decisions are being documented. And when escalations are resolved sooner, this helps expand operational capacity. When these processes work together as a standardized single integrated system, the hospital will benefit from fewer internal transfers, faster placement decisions, greater predictability in patient flow, and increased bed turnover efficiency, which creates more time and space for patient care. This also ensures that the existing beds are being used more efficiently, creating capacity without needing to add a single physical room. I'll now hand it over to my partner, Maddie, to talk to us about our pit crew in action.
Thank you, Samia. With these new workflows, it's crucial that we have the right staff within the Patient Flow Center in order to implement them. This means implementing some new staff within the PFCs and also changing some of the current staff model. One employee we'll implement across all 3 PFCs is our pit boss. This person is responsible for overseeing our pit crew model. They'll track KPIs specifically of the pit crew, assist during surges, and they'll also keep track of our error log. Next, we'll add additional nurse FTEs to the Lafayette Patient Flow Center. This is to help staff up their front line. They will assist the driving physician in assigning the acuity level and also help with the calls between the receiving and referring physician. Then we have our pit crew leads. These were formerly known as bed planning coordinators within the Patient Flow Center. They are the leaders of our pit crew model and assist in contacting all necessary resources for a transfer. And then last but certainly not least, we have our driving physician. This was previously known as the pilot physician within the PFC, but has been renamed to more closely align with our pit crew model. Their responsibilities remain unchanged. All of this flows into our pit crew in action. The car is our transfer request. As soon as it arrives at the Patient Flow Center, the spotter, or our pit boss, is responsible for overseeing the operations. The front of the car needs to be lifted, which is the responsibility of our front jackman, or our nurses, and driving physician. They're able to immediately assign the acuity level using our acuity SOP, effectively reducing time to physician acceptance because we have a clear understanding of the patient's needs and clinical status. The back of the car also needs to be lifted, the responsibility of our rear jackman or our PFC coordinators. They're responsible for confirming the acuity level assigned and ensuring that all documentation is ready and appropriate for the transfer. Now we need to remove the old tires. This is the responsibility of our bed planners. They'll use our bed match SOP to assign a patient a bed based on their needs and other factors like close to home and what treatments they may need. This ensures that the time to bed assignment is reduced and the patient's needs are met immediately upon arrival. Now we'll put our new tires on, which is the responsibility of our pit crew leads. They will contact all necessary resources for a transfer through an Epic secure chat. This could be transport, the blood bank, pharmacy, unit charge nurses, or anyone else who needs to be notified of the patient's arrival. This allows all of these people to work in a parallel process without delays and ensure that the patient can get back on track as soon as they are within our centers. Now, we know with any new implementation, there's likely to be errors. This is why we'll implement an error log across all 3 patient flow centers. Any employee in the PFCs has the ability to report an error. This could be a communication error, an acuity assignment error, or bed match assignment error. Once the error is submitted, it gets sent directly to our pit boss. They're responsible for changing it to in progress on our error log once it's been acknowledged, and sitting down with the staff member who made the error to do a root cause analysis so we can understand why the error happened and how we can prevent it from happening again in the future. We'll also hold monthly meetings within the PFCs in order to review the most commonly reported errors so all of our staff are able to give feedback and we continue to ensure our operations are running smoothly. Now that we've standardized all procedures and we've been sure that they're reinforced, we can enhance operations through an AI predictive model. Our team looked at a couple different AI predictive models that Ochsner could implement with some of the following features. The first being dynamic discharge prediction. This allows us to have a better idea of when patients might be going home and when we'll have additional capacity within our hospitals. We also have barrier management. This looks at social determinants of health and other resources a patient might need before going home, so we ensure that they have everything they need and we don't delay their discharge. Then we have an intelligent escalation system, which perfectly flows with our escalation SOP and ensures that we are contacting the right people at the right time in times of need. And lastly, we have surge prediction. This allows us to proactively plan for capacity constraints so we can continue serving our communities without any delays. This is a high-level overview of our timeline. In year 1, we'll standardize all procedures within New Orleans Patient Flow Center. Then in Q3 and Q4, we'll put our pit crew into action along with our error log. In year 2, we repeat this process with our system-wide rollout to the Shreveport and Lafayette Patient Flow Centers. And then in year 3, we'll implement our AI predictive model. I'll now pass it back over to Jansen.
Thank you, Maddie. Now it's time to answer the million-dollar question of how are we actually able to create capacity and how much without this physical expansion. In year 1, with our initial rollout of our SOP to the New Orleans PFC, by reducing transfer time by just 30 minutes across those patients, we predict we can unlock 73 beds. Followed by the year 2 expansion to Lafayette and Shreveport with a 45-minute reduction, we predict we can open 190 beds. Followed by the year 3, when the floodgates start to open and we open out to the New Orleans PFC with our SOP and AI predictive model, we predict we can open 352 beds. When looking at these numbers, it's very important to know this isn't just capacity created, but patients we've served better. This is a high-level overview of our PFC pro forma. As you can see, bed capacity created has a direct correlation with net patient revenue generated. In years 1 and 2, our main expense driver will be our staffing model, which Maddie went over, followed by a $5 million allocation for our AI implementation expenses. In just 3 years, we predict we can nearly double our initial investment of $8.65 million. With any change management model this large, there will always be risks. Some of these risks include resistance to change, which we will mitigate with our spare model, as well as staff and patient feedback, non-compliance with SOPs, which we will mitigate with our error logs in order to have a closed feedback system in order to attack these problems at their foundation. Along with this, we will have the possibility of hitting costs with AI implementation, staffing, or recruiting. With this, we have phased implementation. By rolling out to the New Orleans PFC first, we can better understand the initial costs so we can better forecast our budget out through those 3 years. Similar to an F1 pit crew, we will also be tracking KPIs. Some KPIs me and my team have chosen are accepted to miss transfer ratio, which will start at 4-to-1 and will jump all the way up to 7-to-1. Capacity created, which will be 73 beds all the way up to 352 beds, and an average transfer time for those level 2 patients of 11 hours and 18 minutes all the way down to 9 hours and 33 minutes. With everything we've stated with our SOPs, AI predictive model throughout all 3 PFCs, we can unequivocally say that we will provide better care to not only the patients of Ochsner Health, but the community of the Gulf South as a whole. Thank you.
All right, thank you. I'll now reset the clock and we'll begin the Q&A portion. Judges, take it away.
Great job, guys.
Thank you.
Loved it. Already stealing that pit boss. I'm loving it. So I heard you guys say in working this project to get transfer times down to 9 hours and 33 minutes. You talked a little bit about the national average, us being now on the high end and getting us more to the lower end. I'd love to know, doing the research that you did, what did you find the national average to be as far as transfer time?
So according to the National Health Institute, we found that average to be somewhere for level 2 patients or people, they tracked acuity differently, but between that 8 to 12 hour range. And that's the average. The median was closer to that 6-hour range, which I know you discussed yesterday. And we understand that getting that number down, we can not only create more capacity, but we will produce better patient outcomes, because we understand the longer these patients wait, whenever there are open beds, there's going to be worse outcomes for those patients. So that was the average that we went off of.
And then I'm really curious. I'm loving if we do decrease 30 minutes and this unlocks 73 beds, how did you do the configuring to know that that would open up 73 beds?
So this is just an example. Sorry. So this is just an example question, and I kept the numbers pretty simple, so it was easy for us to look at. So if you take transfers per day, which were 64, which was the case for Ochsner, and we took that number down to just count for the New Orleans PFC. So let's say the average transfer time would be 11 hours and 48 minutes. We would reduce this to 4 hours, which I think would be the end goal at the time of our consulting is over. In order to get us below that national average, we said bed hours freed per day would be 256 hours per day. The average length of stay by national average would be 5.5 days, according to NHI. This would create bed capacity of 10.7 beds per day. And in this example, it would be 710 additional patients per year.
Fantastic. Fantastic job, guys. Thank you very much for your time. My question is, at the very beginning, you did mention different stakeholders. Where do you foresee the challenges lying outside of the patient flow center, but within our organization?
Yeah, absolutely. That's a great question. I think the stakeholders we identified were the ones that we felt mainly would help with our implementation and be, kind of the champions of this project. We do recognize that there will be additional stakeholders, especially in a large academic medical center like Ochsner. You have people, residents, fellows, students, people like there that also need to be involved in these workflows. I do think as we implement this process, further engaging those people so they can understand how their workflows change and understand the true transfer process will be absolutely crucial in making this work. So it starts in the PFC with those staff in our community hospitals and those resources. We know that it'll have to expand over time to include all of those people so everyone can be bought into our plan and work in one parallel process.
So along those same lines then, one of the real world challenges that we face is spread and scale of the information or dissemination of information that once we've made a system decision that impacts all of our physicians and APPs and such. Describe how you would go about educating the masses as it relates to these types of changes that we'd be making.
Yeah, that is definitely a struggle. It's a great question. I think one of the best ways to do this is you kind of identify your physician or your APP champions, people who you know are ready and excited about change. And then you kind of take them through a rapid process improvement workshop and you educate them on the new processes. And then they take it back to their staff and educate and motivate them. And then from there, it keeps expanding so everyone can be bought in with the implementation.
I guess another note that I took, and I was excited to hear you talk about us speeding up our acceptance, and you talked a little bit about an acuity SOP. Can you elaborate a little bit more on that?
Yeah, absolutely. So we created a flow chart, and the flow chart is an ESI algorithm that is nationally used. And our theory is that when patients are assigned the right bed at the right time, then essentially they won't have to be transferred later in their care. And that just prevents any future delays. And then if they're not being moved more often throughout the system, which is whether it's intra-facility or inter-facility, then they could basically just reduce that transfer time overall. And then that, like Jansen mentioned, we just serve more patients of of the community in the Gulf South.
All right. Thank you for your presentation. The awards announcement will take place at 5:30 p.m. here in the conference center. Thank you for your time.
Thank you guys so much.
Thank you, guys.
Oh, you're good.
final round of the OSU first year student case competition. We're excited to have you here. My name is Tyler Matt. I'll be your host for your presentation. And I'll read through the rules, recap the guidelines, allow you to introduce yourselves, and then we'll get started. So much like the first round, 15 minutes for your official presentation. At the 2-minute warning period, I will hold up the 2-minute sign. And when time has elapsed, I'll hold up the stop sign and say time. That'll be followed by a 10-minute Q&A period. I'll reset the clock. Same thing, same signs. Right. And as a reminder, please don't reference your university. Any teams that do, will be disqualified. We'll now ask you to introduce yourselves to the judges. Please state your name and your team letter.
For Team L, my name is Sienna Arneson.
My name is Asia Lewis.
My name is Jassim Abdallah.
All right, fantastic. You may begin when you are ready. I will start the clock when you begin.
Presenting our solution for optimizing Austria's Patient Flow Center with the PACE initiative. My name is Sienna Arneson, and I'm joined here with Jasmine Abdallah and Asia Lewis, and we are River Crest Consulting. On today's agenda, we'll start off with the landscape of the Patient Flow Center, propose our PACE initiative, along with the implementation plan, followed by our financial analysis and key performance indicators, and then we will leave you with some final words. Starting off with the landscape. Austria's Patient Flow Center, or otherwise known as the PFC, facilitates system-wide transfers by managing end-to-end patient movement, capacity across the system, and optimizing overall throughput.
Starting off with strengths from our SWOT analysis, Austria utilizes Epic to seamlessly exchange patient health information. Additionally, they have implemented multiple AI tools to streamline operational workflow in different departments. And finally, their strong relationships with community partners allows them to provide patients with resources. However, there are also areas for improvement. Starting off is extended discharge delays, particularly for patients with social determinants of health or SDOH needs, driving throughput challenges. Additionally, PFC staff are able to see available beds across facilities, but they are not able to see if those beds are safely staffed, driving transfer delays. On top of that, there are external pressures that threaten the PFC's workflow. Starting off is chronic disease burden, followed by reduced capacity of acute care facilities, and inpatient volume is expected to grow by 3 to 5% over the next 10 years.
To make these weaknesses more tangible, we'd like you to meet John. John is a 73-year-old medically complex patient who lives alone and suffers from food insecurity, housing instability, and lacks transportation. John is currently awaiting transfer into an Ochsner facility for treatment for his respiratory failure and sepsis, and he's wondering what's taking so long. Behind the scenes, Ava, a nurse at the PFC, is working hard to find John a bed. She manages a heavy caseload, coordinating nearly 60 transfers a day alongside her fellow coordinators and bed planners. This is Ava's current workflow, but despite the structured process, she notices delays between steps 2 and 4 after a request is received, but before a bed is assigned. This segment alone takes nearly 9 hours, during which Ava is tasked with determining patient acuity, prioritizing competing bed requests, identifying open appropriate beds, and performing repeat outreach to accepting providers. And at the same time, the referring providers are left without updates, and patients like John are left waiting with no clear timeline.
Ochsner can utilize its Epic infrastructure and AI capabilities to integrate siloed data, improve real-time decision-making, and streamline patient flow. As a result, this will reduce transfer delays, readmissions for patients with SDOH needs, and lengths of stay for patients discharged to a post-acute care facility.
We plan to leverage these opportunities with our PACE initiative. PACE is built on 4 principles: predicting capacity, aligning care, coordinating resources, and eliminating barriers. Our PACE framework has 2 pillars. The first is incoming transfer optimization, which strengthens Epic EHR capabilities. The second is post-acute transition optimization, which removes discharge barriers by connecting patients to the right post-acute resources. Together, these pillars support the full patient journey. Starting off with incoming transfer optimization. The first part of our initiative is the Epic Deterioration Index, or the EDI, which is a probability score out of 100 predicting clinical deterioration. It is automatically generated every 15 minutes within Epic and currently used in Ochsner's inpatient settings. We propose servicing the score directly into the PFC. So now, Ava would have an EDI score for John, and she would be able to use it as an objective, data-driven tool to help determine acuity. Next, we have predictive capacity intelligence. Currently, the PFC is using Epic Grand Central for bed prediction algorithm. We propose strengthening that model with existing Ochsner tools, such as M7 for nurse staffing and IQ for OR utilization. Through an application programming interface, this would not only give the PFC a real-time view of bed availability, but if there's the staffing, able to support it. Building on that, the strength and capacity intelligence and the determined acuity score, which feed directly into the patient transfer matrix, a weighted scoring model that prioritizes patients and then places them. Priority is a weighted combination of acuity, wait time, and system impact, with acuity holding the greatest weight. Then, placement considers 4 variables: medical capability, staffing, bed availability, and regional proximity to determine the best destination. The matrix would then produce a recommended transfer for John, and Ava would have the option to accept or override that transfer, leaving all the clinical decision-making in her hands.
Final component of our incoming transfer optimization pillar is Epic Haiku, an app that is already routinely used by Ochsner physicians for secure communication. With our solution, Ava will be able to send a real-time transfer request directly to the accepting physician, complete with necessary transfer information and a yes-no option. This yes-no option is not a clinical commitment, but rather a signal of availability and willingness to sit down and discuss the transfer. And if there's no response, within 30 minutes, the system will automatically escalate the request to the next available physician. But this also closes the loop for the referring provider. Now, when Ava's working the transfer request, with every status change within Epic, an automatic SMS update will be sent to the referring provider, letting them know exactly where their patient is at in the transfer process. So instead of calling repeatedly or placing their patients elsewhere, the referring provider now stays informed, engaged, and in the loop, reducing missed transfers. And for patients like John, this means faster movement into the care he needs. But while this helps us move patients into the system, we need to be just as effective at how we move them out, which brings us to our second pillar, post-acute transition optimization. We begin by expanding Ochsner's existing relationship with Bamboo Health. Bamboo Health is a real-time care coordination platform that connects providers, health systems, and post-acute facilities. Bamboo is already used by Ochsner today in Epic through NARCS Care, where it delivers real-time controlled substance history directly into the clinical workflow and has led to a 43% increase in provider engagement. Specifically, we propose expanding on the success of this existing integration by unlocking 5 capabilities. Bamboo will help Ochsner identify discharge barriers early through rising risk flags, match patients to the most appropriate post-acute setting, help streamline prior authorization by pre-populating necessary information, and offer a more robust patient history through its connection to the Louisiana Health Information Exchange. It will also enable post-acute network visibility, enabling providers to track their patients after they've left to see how they've progressed after discharge. And this is what it will look like for discharge coordinators. On one screen, discharge coordinators will be able to see rising risk, match patients to post-acute facilities, and verify insurance. But while Bamboo gives Ochsner the visibility to move patients through the system, it can't control what happens outside of it, which brings us to our next and final solution, community health workers. Community health workers are the best choice because their cultural competence and regional familiarity enable them to most effectively navigate local resources and tailor solutions specific to each patient. And this works because Ochsner already has the network to support it. Throughout its rich history in the Gulf South, it has developed deep relationships with community partners who address issues like food insecurity, lack of transportation, and so much more. What we are proposing is centralizing and activating these resources. So here's what changes operationally. On day 1, community health workers can see the SDOH flags directly in their Epic, enhanced by Bamboo's data. They'll then immediately begin coordinating with facility-level case management and the community partners to proactively address those discharge barriers, making it so that patients can leave when they are medically ready, reducing length of stay, and freeing up beds for incoming transfers.
And this is what Ava's final dashboard will look like. With our solutions, she will be able to see John's EDI score, recommended facility for transfer, and that there is an ICU bed available, and the SDOH flags that her fellow community health workers will see as they start providing John with the correct resources.
Now moving on to our implementation plan for PACE. We recommend a tiered governance structure. Shown in dark blue is the PACE Steering Committee, chaired by Ochsner's Chief Operating Officer. They will meet biannually to assess progress and set strategic priorities. Supporting them in light blue is the PACE subcommittee. They will meet quarterly to review ongoing initiatives and escalate any challenges to the steering committee. With these committees established, that brings us to change management. On the incoming transfer side, we will utilize governance agreements to standardize protocols, physician champions to drive the adoption of EPIC enhancements, and continuous feedback through quarterly surveys with committee review. For post-acute transitions optimization change management, we will utilize peer champions from PFC staff to drive the adoption of Bamboo Health, as well as structured outreach processes for community health workers and continuous feedback through biannual survey, pulling information from community partners, PFC staff, and post-acute facilities.
Moving into the implementation timeline of our incoming transfer optimization pillar, we allocated the first 2 quarters for integration and build out of our EPIC enhancements. Training will begin in quarters 2 and 3 and persist periodically, with full implementation at the end of quarter 2. The evaluation phase shows when the 2 committees will meet. Next, for our post-acute transition optimization pillar, we accommodated 2 months for the recruitment and hiring of the community health workers, followed by 1 month of training. Those community health workers will begin working at the beginning of quarter 2, and in the meantime, the Bamboo Health integration and build out will begin through quarter 4, and implementation will begin in quarter 5.
Now for risk management. The first risk that we identified is patient inflow exceeding throughput, making beds the constraint. We propose to mitigate this through strengthening relationships with community hospitals and establishing formal repatriation agreements so that patients can return once they are medically stable. We also suggest utilizing community health workers to address those downstream discharge barriers proactively. The second risk we identified is network gaps and data decay. This occurs when network gaps and outdated data lead to reduced visibility and decision accuracy. We propose to mitigate this through utilizing Bamboo Health's dedicated implementation liaison to validate network data prior to total integration. We also recommend holding Bamboo contractually obligated to ensure that the data amongst participating facilities is accurate and up to date. The third and final risk that we identified is tech build resource capacity strain. This occurs when simultaneous builds draw heavily on a system's resources, leading to delayed implementation. We recommend mitigating this through milestone-based escalation to leadership when progress stalls, and by cordoning off a small portion of the 70-person EPIC adoption army that's in Ochsner's possession. We also recommend leveraging Bamboo Health's dedicated implementation team so as not to draw further upon Ochsner's resources.
Moving into our financial analysis. Overall, we anticipate the total investment of our initiative to be $8.4 million, followed by a total financial benefit of $173.7 million, which includes bed days saved, additional patients served, and reduced cost of readmission for SDOH patients. Moving into the total cost of year 1, we anticipate $4.3 million to be spent. This includes one-time costs of our EPIC enhancements in Bamboo Health, as well as the staffing costs of our EPIC program managers, IT analysts, and community health workers. For the costs of years 2 and 3, we anticipate $1.9 to $2 million to be spent, which includes the maintenance costs of EPIC enhancements, Bamboo Health, and staffing costs totaling $3.9 million. For cost savings of our incoming transfer optimization pillar, we anticipate $28.7 million to be saved, which includes bed days saved as a result of time saved from transfers. For the post-acute transition optimization pillar, we anticipate $148.9 million to be saved, which includes the cost saved from readmissions for patients with SDOH needs, as well as lower lengths of stay for patients discharged to a post-acute care facility. To evaluate the implementation of our initiative, we propose 6 KPIs. We anticipate return transfers and SDOH-related readmission rate to be reduced, followed by transfer matrix utilization to be utilized 75% of the time. Additionally, we aim for physician acceptance time, bed assignment time, and controllable missed transfers to be reduced, and we anticipate the bed assignment time to be reduced by 25%.
Now, going back to Ava and John to see the benefits of PACE. Ava will now experience fewer phone calls, a streamlined workflow, with less administrative burden so she can focus on what she's there to do, serve patients.
For John, this means getting the right care faster, support once he's discharged, and staying informed throughout the process, leaving him healthier and happier with the care that he received at Ochsner.
Ochsner already provides a strong foundation with the Patient Flow Center, but inefficiencies in discharges, transfers, and data visibility slow the system down. The PACE initiative targets these gaps so patients can move through the system more efficiently, meaning they will receive the right care at the right time. Thank you. We are now open for questions.
All right, thank you. We'll now begin the question and answer portion. Judges, take it away.
Thank you. Excellent job. You had mentioned specifically the return transfer process and trying to ensure that we had the right agreements to get patients back to the campuses that they came from. That is something that we talk about and have some risk in terms of there are many hospitals that will call us and call another transfer center at the same time, and whoever answers first or gets the patient there quick enough. Our concern is that if the other campus does not require the return transfer agreement, that they may be more willing to send those transfers there. How do you think we would mitigate that?
We would mitigate that through our community health workers. They'll coordinate amongst facility level case management. That doesn't just mean internally, that also includes external facilities, because those resources need to be connected across the entire continuum, whether that's within the Ochsner system or outside of the Ochsner system. Throughout that process, we hope to see those community health workers develop close relationships with their counterparts at external facilities and hear their needs and tailor our agreements accordingly and see whether or not that's feasible.
Thank you.
Mm-hmm.
Can you share a little bit more? I was really interested when you started talking about a weighted scoring model. I love steering the ship towards a objective way to plan patients. Oh, great. Yeah, I'd love to hear about this.
Yeah, absolutely. So we have three factors: acuity, wait time, and system impact. And the X1, X2, and X3 are weights that would be determined by Ochsner system. However, we do recommend placing acuity in the highest weight. System, I'll break it down one by one. So acuity, that's a physician or a nurse decision. That's clinical, not really something to be touched upon. But wait time, we would scale that on a 1 to 5 scale so that everything is normalized within the total priority score, which would be out of 5. So for example, 1 hour would be 1 point, anywhere from 2 to 3 would be 2 points, 3 to 4, 3 points, so on and so forth. And 5 would be that 6-hour mark that is crucial. So that all factors in. And system impact, what we're looking at there is, are we relieving congestion in the ED? Is this patient demanding an ICU bed? How much is that worth to Ochsner as a whole? That's not something that we were able to determine, but that would be up to system management.
Then the placement looks at those 4 variables that I mentioned before to ensure that that placement is also having an objective tool to determine that placement.
I'm just curious if there was one additional data point we had provided or piece of information that you would have liked to have had, what would that be?
One additional data point. I mean, there are a few. Yeah, there are definitely a few. But if I had to pick one, I really would have liked to have seen what facilities have the most ED congestion. I would have liked to have tailored that to specific populations, looking at the CHNAs for those relative locations.
You guys touched briefly on it. Something that we've actually had a significant challenge in obtaining is voice of the customer. And you guys had mentioned that you would solicit feedback. Operationally speaking, because we have such expansive scale, and we are across the entire state of Louisiana into Mississippi, give me an idea of how you would go about doing that.
Actually have an example survey for the post-acute. Oh, that's anything. Sorry about that. We have an example survey for the post-acute transition side, where we will be pulling feedback from community partners, internally PFC staff, and as well as post-acute facilities. So each of them will be catered to depending on who the audience is, as Ochsner would like to know the differences between, maybe weighted from a scale of 1 to 5.
Along these lines, though, a significant portion of our transfers are coming from facilities that we don't have any actual ability to interface with virtually, for instance, because they're not on our version of Epic. How would you actually go about doing this?
The survey itself could be facilitated via something like Qualtrics or an email. And then using those data analysts that we hired, we would trend that data month to month and escalate that to the steering committee, subcommittee, and whoever might need to see it.
All right, thank you for your presentation. The awards announcement will take place at 5:30 p.m. here in the conference center. Thank you for your time.
Thank you.
What's in my pocket, but I've got the thing.
All right, welcome and congratulations once again on making it to the final round of the OSU First Year Student Case Competition. We're excited to have you competing. My name is Tyler. I'm Matt, and I'll be the host for your presentation. Go through the rules, have you introduce yourselves, and then we will get this thing started. All right, so much like the first round, you have 15 minutes for your presentation. When we approach the 2-minute warning mark, much like before, I will hold up the 2-minute warning sign, and when time elapses, I will hold up the stop sign and say time, and you will stop immediately. Then we will reset the timer for a 10-minute Q&A session. So the judges will lead. Same thing, 2-minute warning sign, stop time. And as a reminder, do not reference anything about your university. That will be a disqualifying scenario. We'll now ask you to introduce yourselves to the judges with your names and your team letter.
I'm Ryan Dallavalley, and we are Team F.
Hi, I'm Audrey Richards.
I'm Max Gilman.
Excellent. I will start the timer when you begin.
Good afternoon. I'm Max Gilman,
I'm Ryan Dallavalley.
And I'm Audrey Richards.
and we are representatives from RAM Consulting Group. When looking at Oxnard Health System, they're facing a critical capacity strain for their level 2 transfers. This is due to the subjectivity in their command center, and this is leading to delays in their transfer process. Today, we're going to be walking through our background, a little background on Oxnard Health. Then we're going to look at the assessment as well as some of the opportunities we identified. Then we're going to look at our solution. Then I'll personally walk you through the user experience. Then we'll look at the adoption. Then we'll wrap things up with our financials and then our value and impact.
So getting started with some background, we're looking and discussing Oshner Health today, which currently employs 4,900 physicians and has 5,000 beds. They see 1.6 million patients each year across their 47 hospitals and 370 locations. Digging a little deeper into what that really looks like, we've identified 3 hospitals as the main source of their clinical capacity strain, those being Jefferson Highway, Oxnard Lafayette, and Shreveport Hospital. And it is at these 3 locations that we see the highest volume of accepting transfer patients, resulting in demand for complex cases outpacing bed and physician availability. Because we're looking at Oxnard Health today, we believe that any solution has to identify with their mission, vision, and values, which is why our solution will inspire healthier lives and stronger communities. We identified a specific opportunity for Oxnard Health in their miscontrollable transfers, as they see over 2,000 each year. Additionally, their current state transfer process takes a median of 6 hours and 20 minutes.
Now that we're grounded in their scope, their system, and how they operate, I want to shift us into thinking about how are they performing today. We conducted a SWOT analysis and saw that they have a great strength with their centralized patient flow center. And additionally, they have Epic across their 47 hospitals, allowing for system-wide integration. Overall, this provides a great operational and technical foundation. However, when evaluating the process, we did notice some weaknesses, including that the prioritization process is subjective, so there may be some inconsistencies in decision-making, and it's a manual process, so it's time-consuming. Overall, Oxnard has a great infrastructure, but the workflow may create some bottlenecks, thus lending to opportunities, including to standardize the patient placement system, as well as leveraging Epic to automate and support the decision-making process. This is especially important as there are market threats, including that delays in patient transfers may cause potential patient leakage. Additionally, we do know that demand is growing at Oxnard, and that will put strain on an already manual system. Next, we wanted to evaluate where in the process these challenges are occurring. So we looked at the current transfer process, which start to finish takes 6 hours and 20 minutes. We wanted to focus our attention to steps 3 and 4, as this takes over half of the transfer time. And thus we focused our efforts here, where we believe we can get a 30-minute reduction and achieve a $4,300 a day revenue opportunity. We came up with a list of features and capabilities we thought to be essential to assist with this process. And of course, first started with Epic, the current EHR, which unfortunately did not have all of these features and capabilities. Thus, we looked across the market and didn't find a software that met all of these features and capabilities. However, LeanTOS and Central Logics had a few, but still a market gap persisted, and thus we chose to create a new software, Accept IQ.
I'm excited to present to you today Accept IQ, our solution for streamlining level 2 transfers, facilitating physician communication, and identifying patients eligible for back transfers. Accept IQ will be seamlessly integrated into Epic, ensuring that providers don't need to log into different systems in order to use our software. Additionally, because we're seamlessly integrated, we'll be able to have notifications go directly to their Epic inboxes. And since we work constantly in the background, we'll have access to real-time patient data for advanced analytics. Digging a little deeper into the technical architecture, we're going to start up at the top where we have our data coming in from both the real-time feed as well as the historical database, feeding into our Azure-based repository. From there, it feeds into our Accept IQ AI model, and that's really our secret sauce. From that AI model, we score the patient need and create a clinical snapshot, which gets sent to all of our hospital physicians. Simultaneously, the AI model will recommend different hospitals and send that to our patient flow center, all the while having a one-click workflow opportunity for all of our care team members. We decided to use a Microsoft Azure-based data repository because it's eligible for HIPAA compliance. And bringing it back to that Epic integration, we really wanted to ensure that our providers are working on the screens they're already used to seeing every day. So now that we know what Accept IQ needs to do, let's talk about how we can develop it. We believe that Ochsner already has all of the tools that they need at their disposal. We would recommend using Innovation Ochsner, the in-house tech development team that specializes in using digital health and advanced analytics. And using this team will reduce costs in the long run through the development process. And now let's take a look at how Accept IQ can be used on a daily basis. So just a quick refresher, this is the current state process that we're working with that currently takes a total of 6 hours and 20 minutes. And I'm excited to introduce to you today our 4 care team members that we're going to be using to walk through the process. We've got our transferring physician, Dr. Sam Okafor, our patient flow coordinator, Sarah Jenkins, our receiving physician will be Charlotte Davis, and our case manager today is Justin Clark.
Now I'm going to take you through the user experience process and show you how Accept IQ is directly embedded into Epic. But first, we can't forget about the most important part of the process, the patient. Diane Holloway is 78 years old, a mother, and a grandmother. And we're going to be taking her through the provider view, starting with our initiation phase. Starting with our transferring physician, Dr. Okafor will click on his provider view. You will then see that there is the Epic EHR autofill function that will allow him to automatically fill in Diane Holloway's patient information. From here, it'll make a patient profile, which will create a score for her of 78. It'll also show her transferring facility, which is Lakeview Regional Medical Center. You will click on her profile, where then you will see the patient snapshot, as well as the vitals and some of the prior lab reports. This profile will then be sent over to the command center, where Sarah Jenkins will receive it and see an AI recommendation of which hospital she should be transferred to. In this instance, it's Ochsner Medical Center North Shore. But I want to remind you that this is just a recommendation, and that it is always up to the command center's final say. When selecting the facility, she will select that down arrow, and she will be able to select Ochsner Medical Center North Shore. She will select this and then do a one-click confirmation, sending Diane Holloway over to the receiving physician, where the receiving physician will receive a push notification on their mobile device. Dr. Davis will then be able to push on this notification. It'll open up her receiving physician screen, where she will see the profile for Diane Holloway. She will then see where she is being transferred from, as well as her acuity score. You will select the profile, where you will see all the patient information, the transferring physician, as well as any prior lab reports that might be important. She'll scroll down, and she'll see an accept and deny workflow, where she can easily accept the patient. Once the patient's accepted, she will also be able to chat with Dr. Okafor about anything related to Diane's health. Diane's profile will then be sent back over to the command center, where Sarah Jenkins will then be able to assign her bed. For this instance, she'll be assigned to the surgical unit in orthopedics, where you will click on that and confirm using a one-click workflow. There will also be a notification sent over to Dr. Okafor, which will allow him to see the transferring facility as well as the surgical unit she's been assigned to, and then a one-click confirmation to sign the transfer agreement. Diane Holloway has then gone on to Ochsner Medical Center North Shore, and she has had her surgery, and her profile has been sent over to the case management team, Justin Clark. Justin Clark will now be able to view the case management page, where he'll see the discharge likelihood of all of his patients. He will then notice another page that is the back transfer candidate page. You will select on that. and he will notice Diane Holloway's profile here. He will select on the profile and he will see the AI predicted back transfer percentage. He can then do a one click and confirm and send her profile over to the command center, where Sarah Jenkins then can go into her command center view for back transfers and immediately coordinate that back transfer. And it also provides the return to facility as well as their clinical snapshot. The old process took 3 hours and 45 minutes between steps 1 through 4. The new process takes 3 hours and 15 minutes, saving a 30-minute reduction, with the ultimate time being 5 hours and 50 minutes, which is below that 6-hour threshold that directly relates to patient mortality rates.
Thank you. Now that you understand our integrated system, we understand that you're offered new technology every single day. The deal breaker is going to be whether or not physicians and team members will actually adopt this technology. So we think the deal breaker is a great implementation plan, and ours has 3 components. We plan this in order to have a smooth transition, ensure team members feel adequately prepared and excited about AcceptIQ, as it should benefit them and their patients. We want to test the streamlined algorithm-based transfer system and back transfers by piloting in our cardiology and neurology service lines, as well as at Jefferson Highway, Auctioner Lafayette, and Shreveport hospitals. We selected these service lines and hospitals as they have the highest volume of transfer patients. So we believe if the solution's viable here, it'll be ready for system-wide integration. For our pilot timeline, you'll see software development, training, and pilot implementation, which ends in Q2 of year 2. Moving into Change Champions, we understand we cannot do anything without our team members, so we will rely on Auctioner Health to identify change champions who understand the need for this change and are willing to engage their team members and assist with change management. To support our change champions, we'll provide a variety of resources for different learning styles, including webinars, user playbooks, and tutorial videos. We've identified risks and created mitigation strategies for those, starting with algorithmic bias. We'll have monthly bias checks, and the AI governance committee will need to be involved from the very start. Additionally, we understand that some providers might be resistant towards this change, which is where we'll really rely on our change champions, as well as ensure there are ample opportunities for feedback and transparency. We also don't want to overwhelm these community hospitals, so we will ensure we have capability-based routing rules and that community hospitals are involved in that process from the very beginning. Additionally, we understand that some patients might be hesitant to transfer back to their community hospital, so there will need to be education and assurance that they're still receiving that same great quality from Auctioner Health, which is closer to home and closer to their families where they can heal there. Finally, you'll see our 3-year timeline, which has the pilot concluding in the middle of year 2, beginning system-wide integration.
As Audrey just mentioned, we're planning to have a 3-year system-wide expansion plan, so let's look at how financially viable that is. Right here, we have our AcceptIQ pro forma income statement, and I want to draw your attention to 3 important numbers. First, we'll have our total cumulative revenue opportunity across 3 years of $38.4 million. And now looking at our total costs, again, across all 3 years, it's $3.5 million for a total net operating income of $34.9 million. And again, we're looking to be financially positive by the end of year 2.
Now, what will the impact of AcceptIQ be on Auctioner Health? Operationally, we expect to see a decreased length of stay, which would allow Auctioner to see more patients. So many so, in fact, that it would be equivalent to adding 21 beds across the system without the added cost, might I add. And financially, as Ryan mentioned, there's a $38.4 million revenue opportunity, which comes out to a whopping 995% return on investment. This is based on transfer time reduction of 30 minutes, as well as making sure we capture those eligible back transfer patients to get them back closer to home. Now, how will we measure the progress and success of AcceptIQ? We project to see a decrease in length of stay, decrease in readmission rate, and an overall improved patient experience.
Now, when looking at the outlook for AcceptIQ, the new in-transit function, which would allow transferring and receiving providers to have real-time tracking of their patients. It will also have a discharge optimization, which will allow them to reduce the peaks at 11 a.m. and 2 p.m. and create more of a plateau. And finally would be the commercialization of AcceptIQ, allowing others to use the operating system. Through using AcceptIQ, Sam Okafor now has a fast, efficient way to treat his patients. Sarah Jenkins now has AI optimization and has an objective process for placing patients. Charlotte Davis now has a one-click workflow on her mobile device where she can accept or deny patients. and Justin Clark can get patients back to their community for recovery. Thank you. And if you would like to take a patient through the process yourself, you can scan this QR code and access Accept IQ's wireframe.
Thank you.
Thank you. Thank you. We will now begin our question and answer portion. Judges, you may begin.
Fantastic job, guys. Thank you so much. Obviously, being that this is a conceptual discussion because the model hasn't been built, I'm sure we have tons of questions on that. The one that struck me first was how will your model actually predict the percentage need of a return transfer, back transfer, repatriation?
Yes. So in the model, can you click on the appendix slide for that? It has a, so it's based on length of stay, as well as the, where patients are within the transferring facility. So for the back transfers, for instance, it allows them to see how many patients are within the current capacity. The current capacity of the facility, as well as the diagnosis complexity and the clinical stability of the patient. So that is all ranked within the software. And that's what ultimately drives that percentage for the patient.
One other question. You guys came up with a pretty robust list for your features and capabilities. How did you land on those?
Yeah, so when deciding our capabilities, we did a lot of interviews with people in the field. We really want to talk to physicians, number one, somebody in the command center, number two, and then other administrators. So when talking with physicians, the main thing that I noticed when talking with them was that they needed a uniform system for communication. So that's where we wanted to bring it all on the mobile phone for them. They're always up and going. They're not going to be on their laptop, so our computer. So we wanted to have a mobile device option for them. That was very big for the physicians we talked to. And in the command center, we noticed another thing was with the back transfers, that was another capability, was the identification of that. They found it hard to identify when they are able to send the back transfers. So those are two of the main capabilities, and we did it through talking with providers in the field.
And additionally, we were really looking, one of the main issues that we found was this current subjective process. And so we were thinking about ways that we could help to turn that into a more objective process. And so that also kind of helped determine the list of, things that we needed in a solution.
We also just did an extensive look at the literature. And again, we also went and watched a transfer occur in real time and tried to understand where the errors were. We knew nothing about patient transfer centers before this case, so it's been really interesting. So we really had to go and watch for ourselves and just ask people in the patient transfer center that had been there for 15 years, what capabilities would help you in your daily work.
All right, well, thank you very much for your presentation. One question I had was, this is very much a technology solution. What other people solution or process solutions or other things that you considered? Because having someone build an entire new software will take some time and some negotiations internally within the system to get a IO to focus on that priority, given other competing priorities. So did you consider any other alternative solutions that were not solely technology related?
Yeah, I think when we first started this process on the Teams Q&A call, we heard someone say battle of the beds. And we felt like, that kind of was what it was, trying to make sure that there were more beds, but without creating more space. So the first thing we considered is, discharge lounges. How do we get patients home quicker? So we looked at My Laurel and saw their hospital at home program. We were really just trying to think, how can we open beds for these patients? Because that seemed to be a major barrier. So I think that's really where the back transfers come in. I know that some back transfers are already occurring, but I know it's hard to identify when it might be time for that. So I think trying to figure out if we could get more back transfers, more patients closer to home would probably be a first priority, which could be done in ways outside of technology.
Additionally, we looked at sort of these mobile hospitals. Atrium's Care One, I believe, was one that we looked at, but that seemed more like a temporary solution, and we were looking for something that could be more long-term. And yeah, so that was another option that we considered.
Okay, and then maybe one follow-up question. So with the automation and there was a lot of, physician having to click buttons and accept things and sign things, which that can be challenging at times. Um, what like how would you go about that that change management process, or if the escalation process? So if they don't like quickly within 30 minutes click the button and accept the patient or do the things or what have you, what kind of escalation processes did you consider?
Yeah, so when looking at the patient flow, through my presentation explaining that, the each individual process on the screens I showed was only one look for each of the individuals. So the receiving physician will only have that notification and then that one touch. And so it'll allow them just to have a quick, simple action to be able to, and we really wanted to be on the phone. That was a very important concept, as well as the case manager to be able to have it on the iPad as well. So that was kind of more what we looked at, was just having the idea of being able to have it on the go. Was more what we looked at.
Did you think about like how if they're in surgery, or how if they're tied up with a complex Dr. Quo is going to help me out with what they're going to be doing.
Yeah, in real world scenarios, what happens is at times we ping somebody if it's Haiku we're using or whatever the app that you're developing, and it pings at 3 a.m. that doctor's dead asleep.
Mm-hmm.
What does our team do from an escalation perspective if that physician is in the OR and doesn't answer the ping, if they're asleep and doesn't answer the ping?
Yeah, so that was also built into the Accept IQ platform, was that it has a backup platform. It was underneath the AR recommendation. It has a backup. So if the first one doesn't work, it automatically reroutes it to the next hospital where it'll be pinging the physician.
I also think we would model the existing escalation pathways as much as possible to integrating this new software, because we understand this is like an issue now, of course, and we hope that maybe nurses and secretaries, people that are working alongside these doctors, could maybe help. We actually want this process to be easier, not harder. So even though there's a lot of clicks, we're hoping it is easier than having to actually go through a patient chart, communicate with another physician, wait for the other physician to call you back, or that kind of process.
I'm interested, can you click on the commercial revenue opportunity? Yeah. Maybe talk me through what all you looked at here. It's something in the state of Louisiana that's a big opportunity for us. We have a really tough payer mix. We're over 70% government payer, and so we are fighting for every commercial patient we can get.
Mm-hmm.
And so I'd love to know a little bit more how you use this data.
Yeah, so we used national averages for a payer mix breakdown to determine sort of what the percentages for each of our revenue categories was going to be. So we took the amount of patients that was in the given data for the transfer breakdowns and broke it out by each service line. And then we took an example case from the CMS table and took the weight from that and multiplied it by a charge factor to get our average charges. And then at the end, after we calculated out through the total amount of patients, through our time savings and everything, we adjusted for the commercial payer mix percentage. So we did 1.05, so 105%, because that was the literature that we found for average commercial reimbursement. So that's the breakdown for how we got to that number. And then we added up all of our different revenue opportunities between commercial versus Medicare versus Medicaid for our overall revenue.
We also think this will increase revenue opportunity through having these higher complexity cases that can sometimes generate a lot of revenue, opening up more beds for them to come to our 3 main hospitals as well.
Part of our current process is recording all the calls between physicians, and that's actually a medical legal protection play on our part. And from a quality perspective, we can reference the call. How would you go about, or did you think about risk mitigation as it relates to medical legal liability in your model?
So the chat function that we have going between the transferring and the receiving physician is HIPAA compliant. I think it might have been mentioned in the presentation, but it was mentioned as secure chat. So that's our HIPAA compliance feature with that.
Yeah, it would definitely be interesting to have some researchers go into and sort of look at all of these different communications and see how they're occurring. And I think this too is why we thought that the automation process is so important to support the control center, but we don't want to take away from that because we do understand that there are times where physicians need to call, and we do want that, maybe documented.
I know we're out of time.
Oh, sorry.
We actually had the opportunity to play around a little bit before, so it's really cool to do. Thank you.
Thank you.
Thank you.
Okay, that's good. Thank you.
All right. Thank you for your presentation. As a reminder, the rewards announcement will take place at 5:30 p.m. here in the auditorium. All right, welcome and congratulations once again on making it to the final round of the OSU first year student case competition. We're excited to have you competing. I'm Tyler Matt. I'll be your host for the presentation. I'm just gonna read through the rules, again, allow you to introduce yourselves, and then we'll get things started. So much like the first round, you'll have 15 minutes to go through your presentation. At the 2-minute warning, I'll hold up the 2-minute sign, and then when time has elapsed, the stop sign, and I will announce time. Same with the Q&A session, which will be 10 minutes long, where we set the timer. Signs will be the same. And then as a reminder, please do not reference your university. Any team that does so will be automatically disqualified. But now I'll ask you to introduce yourselves and your team letter.
Hi, I'm Pernil Kamaya, Team H.
I'm Micah Dennis, Team H.
I'm Keaton Morrison and also on Team H, believe it or not.
Excellent. You may begin when you're ready.
Well, good afternoon, everyone. Thank you for joining us today to hear of our solutions to optimize Ochsner Health's Patient Flow Center. At its core, Ochsner is built on providing specialized care, and with that, we come to you today as Specialized Solutions. I'm Micah Dennis.
I'm Keaton Morrison.
And I'm Pernil Kamaya.
And to ground this conversation, we would like to provide a brief overview of the topics we'll touch on throughout the presentation. We'll start off with some background and then get into our strategies to provide the right care at the right place at the right time. So to start, Ochsner operates one of the largest integrated health systems across Louisiana, Mississippi, and the Gulf South, serving patients from across 47 hospitals and over 370 care sites. With such a scale as this, Ochsner faces a constant demand to efficiently move patients to the right level of care in a timely manner. However, the current transfer process has become increasingly complicated. Ochsner Health's Patient Flow Center is currently experiencing transfer delays as well as constrained inpatient capacity. This is driven by a subjective transfer process along with various discharge barriers that creates a cycle where our patients are waiting longer for transfer while capacities remain constrained.
Mike did a wonderful job outlining the problem facing Ochsner Health Patient Flow Center. As our team dug deeper in the data, we couldn't help but notice the lengthy and variable transfer acceptance process. On the board behind me, you can see the 5 key players in this process, as well as the multiple decision points. These varying decision points result in delays in our patient transfer process that contribute to over 60% of controllable misses across Ochsner Health. We're here today to help you reduce those controllable misses. And I take you to a broader view. We're going to look at Ochsner's internal strengths and weaknesses, as well as their external opportunities and threats. One strength we really would love Ochsner to lean into is that Epic EHR infrastructure. Epic is at the forefront of the EHR revolution and provides many different resources such as cognitive computing and predictive analytics that Ochsner should leverage. As far as weaknesses, we outline the subjective bed assignment process that adds time to our patient transfer flow center. For opportunities, Ochsner has a wide amount of community partners that we hope to lean into when looking at where to place and repatriate our patients. And lastly, as far as threats across the nation, we are seeing a rise in patient acuity and an increase in demand for Ochsner's specialized services. And with that, we bring to you our 4-part solution strategy. Ochsner is already doing something special with their patient flow center, and we believe that these processes can help improve what they do. First, we recommend implementing a system patient placement matrix. This will make the subjective decision process objective and reducing that time to decision making. Next, we're going to redesign the pilot role, physically removing the physician lead of transfer from the transfer center, but keeping his expertise at the forefront of the decisions being made. Next, we're going to establish transfer and repatriation agreements with our community partners, driving shared value across community hospitals and Ochsner. And lastly, we're going to implement discharge lounges at our highest volume transfer centers to increase our bed capacity.
After hearing from your Patient Flow Center leadership speak to us, it was clear that Ochsner is currently experiencing challenges across its patients' entry points, with significant competition for which patients receive a bed assignment first. Solution 1 of our 4-part strategy addresses this through the implementation of a physician-driven patient placement matrix. The matrix we're proposing is designed to address the subjective bed placement process and competition for bed assignments between transfer patients and patients boarding in the ED. This is done through an objective framework for placement across the Ochsner system based on a patient's acuity, diagnosis, and service. Now, before we show you what this matrix will look like, we wanted to discuss our recommended approach for building it. It starts by bringing in your pilots and your physician leaders across every service line who define the placement logic across their respective domains. And a stand-up patient placement council is created made up of patient flow center leadership and physician leadership who maintain it and refine it over time. And the implementation of the matrix comes with the near elimination of subjective bed placements, accelerated bed assignments, and a reduction in ED to ED transfers, which accounted for 1/3 of all 2025 transfers. So here we've actually gone ahead and made the matrix for you. This would be first implemented in Excel as a standard operating procedure, but we've intentionally designed it to be scaled to a database to support future automation inside Epic, which could trigger escalations when a patient has been waiting for a bed for too long. So to actually get inside this matrix, we have every row which is associated with the service line. So you have general surgery on the far left, and across all the columns, every care level is mapped to a specific unit at an Ochsner facility. So how this would work in practice is that once a patient is accepted, their acuity and service line are determined, a bed planner could open up this matrix and immediately identify every predetermined unit across the system that not only has the capabilities to accept that patient, but would also be required to do so. And so the impact of the matrix is that you're able to route transfer patients across a wider pool of beds system-wide without adding a single physical bed. So you're able to increase your capacity. And the result of all of that is it puts less pressure on high traffic units, as well as creating more breathing room for patients boarding in the ED who are competing for these same beds.
Thanks, Pernil. And with that, our second solution is to ensure care at the right place through the use of repatriation agreements. Across the country, rural and community hospitals are undergoing financial turmoil, even being at risk of closure. Between Louisiana and Mississippi, over half of these hospitals are facing the same risk, operating on thin financial margins as well as limited reserves to sustain their operational losses. While Ochsner is facing capacity constraints, our rural and community hospitals are becoming more and more underutilized. To bridge this gap, repatriation will allow Ochsner to safely transport patients back into our community hospitals while preserving their ability to providing that specialized care. Operationally, this will look like the community hospital initiating the transfer and committing to accept the patient back once the care has been provided. Ochsner would then accept that patient and then provide that specialty tertiary and quaternary care, and then start monitoring the patient for clinical stability. Now, once the patient has been deemed clinically stable, the process begins to safely transport that patient back to the community hospital with priority bed placement. This process would be supported with a 24-hour return window alongside a 48-hour maximum hold. But this is a closed loop system to efficiently make sure that our patients are getting to the right level of care in a timely manner. Research shows that successful repatriation is contingent on getting key stakeholder buy-in, and this is between our physicians, nurses, as well as case management, because this would represent a culture shift of not just accepting patients, but also putting them back into community hospitals. And case management is also critical in this process because our clinicians are really busy. So they would have to add their expertise in that coordination, that patient identification, as well as measuring a solid return on investment. This works best when the team is operating as a cohesive unit rather than a siloed entity.
Solution 3 turns our focus back inwards by redesigning the role of the pilot. So the star on this diagram highlights a significant source of delay, and that's the time between a physician accepting a transfer and, a physician taking a request for a transfer and accepting that, as well as the variability in that window. And that variability is an opportunity that this solution targets. So with our redesign comes two key changes. First, with routing, all specialty transfers would go directly to a specialist without the pilot's involvement. The second change would be that the pilot would no longer be physically located in the transfer center and instead focus their time on their normal clinical duties. What would remain, though, is that the pilot would take all hospital medicine and critical care transfer calls while retaining full decision-making authority on whether or not to accept those patients. The result is faster, more consistent acceptance with less variability, as well as clinicians operating at the top of their license.
And the last piece to our patient flow puzzle is to look at our discharge efficiency. Successfully implementing discharge lounges at Ochsner Health will allow us to ensure care at the right time for every patient. Based on our research, we estimate that 68% of patients at Ochsner Health are discharging home. Ochsner already has a robust 200+ post-acute care network set in place, so there's not much there to support that transition from an inpatient bed to home. When looking at hospitals that implement discharge lounges, there's an average of over 5,000+ ED boarding hours saved per month. If we can implement this at Ochsner Health, we can help reduce the control misses by increasing our capacity. Now, how will this look? We recommend having discharge lounges at your 3 highest transfer volume locations, including the Jefferson Highway main campus, Ochsner Lafayette General Medical Center, and Ochsner LSU Shreveport. These discharge lounges will be open from 8 a.m. to 8 p.m. and line pickup before and after work. They'll be staffed by 2 RNs and 2 PCTs, as these discharge lounges
These patients have already been clinically discharged and they don't need a higher level of clinical care. Again, the goal is to improve our bed turnover and reduce our discharge bottlenecks, and they'll be placed near the main entrance to allow for easy flow in and out. So what's the payoff? These discharge lounges, when will be implemented at those locations, we've strategically recommended that they do not build any new buildings, but rather renovate space that we already have. This is estimated to have a net capital investment of $1.22 million. We also estimate a recurring cost of $1.35 million for both the staffing, the upkeep, and the resources of these lounges. You can see our year one cumulative cash flow. We were already in the green by July. We calculated this by estimating 35 patients to use the lounges per day and an average saved inpatient day of 42 minutes per patient that uses it. Again, the 3-year NPV for this is $3.36 million. Now, I know we recommend quite a lot to you today, so let's talk about how we can actually implement this at Ochsner. As healthcare leaders, you all know the hardest part of implementing change sometimes can be the people, but you also know that is where the power lies. That's why we recommend Ochsner Health using a structured change management framework when implementing these changes. We recommend the ADKAR framework, or ADKAR. The first step is to build awareness among your team, and a critical way to do this is to find your clear why and connect with all your stakeholders on why that's important. And at Ochsner, we know the why is the patients. Yesterday, we talked about how when a patient takes over 6 hours to transfer, their outcomes decrease and their risk of mortality skyrockets. This is our why, and we must protect our patients. Next, we must establish desire among our team. It is vital to recognize physician champions that can be early adopters of this change and catalyze that change within their teams. The physician champions ideally are those pilots or those physicians in the highest transfer volume specialties such as cardiology, neurology, and GI. Next up is knowledge and ability. First, you must make sure you have the workforce to implement this change, which we'll talk about later on by hiring on new analysts. You also must equip your staff with the resources and education and knowledge to implement this change. And last is reinforcement. We will set clear targets within the patient flow center and across the enterprise that our stakeholders are aware of, and they know when we achieve them and when we set new ones. Here's a quick outline of what these next 3 years will look like. While it's quite a sprint in the first 2 years, these will pay off in the long run. The patient placement matrix will be created and the council will be stood up within that first 6 months. We'll pilot at our main campus, and then we will implement into our other three transfer sites by year 2. By year 3, we hope to integrate it into the EHR and automate. For repatriation agreements and our pilot redesign, we will establish the new workflows in that first 6 months to a year and go live then. And our discharge lounges will be up and running as soon as renovations and staffing is complete.
Thanks, Keaton. And with that, we understand that transformation of this scale comes with its risk. To address our largest risk, which is that physician adoption of that placement matrix, we want to position our physicians as key stakeholders in building the matrix, as well as we will do some piloting as well. For our operational risks, such as triage quality and repatriation delays, we want to make sure that we've defined clear clinical criteria for repatriation, as well as set up an escalation matrix in case of delay. And then for the lower risk initiatives, such as the discharge lounge, we want to ensure that we're educating our staff, that we have EHR flagging, as well as rapid return protocols. And to support this, we really want to leverage existing resources rather than adding on unnecessary complexity. With this, we recommend that we fully leverage all of the maximum capabilities that's already embedded within Epic, specifically the cognitive computing models, as well as predictive analytics. While these often go underutilized, these are key drivers in successful patient transport as well as throughput. And we also recommend to hire in-house analysts. These analysts can drive optimization of the matrix as well as future automation and maintenance. But ultimately, this will give Ochsner an ability to continue to create scalable, data-driven solutions for future sustainability.
And to bring it home, we'll discuss key measures for success and what it means for Ochsner's future. We've organized key performance indicators around 4 measures tied to the strategies we discussed today. For bed turnover, we're targeting for over 40% of patients discharged before noon. For repatriation, we're aiming for 50% of all eligible patients successfully returned back to their community hospitals. For patient access, we're aiming for a median time of under 30 minutes from a physician accepting a transfer to bed assignment. And given the new changes we're recommending for your current workflows, it's important that your stakeholders are satisfied. So we're targeting for 80% of all Ochsner Patient Flow Center and providers rating the new workflows positively using a Net Promoter Survey. And Ochsner's Patient Flow Center is already doing something extraordinary, serving some of the highest acuity patient populations in the country by coordinating tens of thousands of transfers annually. Our 4 strategies don't rebuild those operations, they sharpen it. We've estimated a 3-year investment of $7.12 million with over $2 million remaining. And every strategy discussed today comes back to 6 keywords: right care, right place, right time. Thank you.
Thank you. The timer is now reset and we'll begin the Q&A portion. Judges.
Thank you. Thank you for your presentation today. I wanted to ask a little bit more about the discharge lounge. Usually anything we do costs, it always is 1 million or more, it feels. So I noticed the 1.2 million investment, was that for just like one site or for 3 discharge lounges? And did you think about like, how did you, I guess, tell me a little bit more, how do you got to that cost, the sizing of the discharge lounge, the location of the discharge lounge, and making sure that people actually want to leave the discharge lounge because it looked pretty nice. So
Of course, yes. So do you first want to tackle the financials? Would that make the most sense? So we can look at our statement of operations. This is just generally how we estimate the operations across what we're implementing. Down here you can see the one-time expense for the discharge lounge renovations, which we have some assumptions later on, which we can go through. Just looking at, we estimated when looking at peers, about 975 square feet per discharge lounge. And we also looked at the average cost of renovating a hospital per square foot, and that's how we got our recommendation for that one time as well. So that's how we got to our one-time renovations, and then we have a recurring cost in our assumptions as well over what it would take to staff it as well. And then with the successful implementation, we were talking about that. So we had the privilege of talking to some subject matter experts, and they really emphasized on having a pull instead of a push system with this discharge lounge. So instead of having it as a last chance resources and pushing patients there when we're already at capacity, we're going to look in that EHR and see, okay, who's eligible and how can we pull them from this inpatient bed as soon as they're eligible and get them in that discharge lounge.
did you think about you kind of hit on it just now, the pull kind of aspect and the cultural aspect. How would you create that pull kind of environment at the facility?
Yeah, that's a great question. I think on someone in the appendix, we have success or keys to success. But right now, as he's finding out, I can speak to that. It's a twofold. One is really just bringing it in our culture, making sure that those that transfer our patients know where it's located, know where it's at, and really making it normal within us. It's just part of our discharge procedure. And then on the other side, on the tech side, we are hoping with Epic that we can implement flagging systems. These patients, when they are eligible, it's flagged in their EHR that we can see they're eligible for this. And again, here's just some key successes in implementation that we want.
Just to follow up on the discharge on. So with the pull, would you physically have someone then like transport, you would dispatch transport to go get that patient? And because I ask that because a lot of times those patients are the easiest ones for the nurses to have in a room because they don't have to do a whole lot. So we don't get the engagement from the staff to be willing to say, basically we're like, hey, why don't you send this patient to the discharge on so we can send you a new admit and put all the work back on you. They're kind of like, you know what, I'm good. I'll just hold on to this one. So how would you get, I guess, how to go deeper into the pull?
Yes, I think that's a great point to bring up too. And I think that really drives home our ADKAR framework, where it's really developing that awareness and the desire and knowledge of saying, okay, maybe this patient and this time is okay to sit in this inpatient bed, but what about someone who's waiting for this bed? What's happening to their outcomes? And so really changing that culture. And again, that ADKAR framework of that desire and knowledge in our team of it's bigger than you, it's about the community. So that's how I answer that question. If that answers your question.
I'm going to ask that question again in a little bit different way. But so I wrote down that the staffing model for the discharge lounge, 2 RNs, 2 PCTs. And so I guess my question is, when I put my nurse hat on, what is the task and the role that we want to use that RN for in that discharge lounge? And are we leveraging that nurse? Because we know it's difficult to staff nursing today. Are we using that nurse in that lounge to do the pull?
You asked to do the pull. Are you asking if she's looking here? She is looking in that EHR for that.
Right. Are you using is that the idea for the nurse?
That's a great question. I think that is a role that she could have, but also it's just to have them there where sometimes in discharge lounges, there's just a PCT, there's a phone that, goes to the nurse's desk, and it's more to have her there just in case something does happen to those patients.
Sure. Have you considered LPNs in the model as well?
That's a great question. I think that is definitely something to consider in looking at how can we really staff this as well. We're happy to work with you on what's the best staffing model.
Sure. Yeah.
Yeah.
One of the things that you wrote at on your SWOT analysis initially was professionals not practicing at the top of their license. Staying on the topic of the discharge lounge, how did you get more granular with me here? How did you actually land on your staffing model and also on your hours of operation?
And so when it comes to staffing model, that is we saw that we expect to see 35 patients a day and filling those 10 chairs. We want to make sure that we don't have, someone needs to be there for everyone there. You know, you can't just have one PCT for when there's 10 people in the room. So kind of looking at those ratios, how we staff that model. And then if you wouldn't mind, would you mind reminding me the last part of your question too?
Oh, just your staffing model and your hours of operation.
Yes, the hours of operation, we really want to be able to have pickup before and after work. And again, starting at 8 a.m., that allows us to discharge patients before that noon mark, really to go back to our KPIs. And I think when looking at when patients are discharged before noon, the hospital just operates on a much better capacity.
All right, I think we're going to move on from the discharge lounge. Next question was really around like patient acceptance of the repatriation back to their community hospital. Kind of, did you think about that? Consider what that looks like? Because 50%, I don't know what we are today, but probably not 50%. How would you go about? Oh goodness, what's kind of your thoughts on patient acceptance of that?
Sure. And with that, patient experience was really centralized in the solution. If you've ever had a family member that's in an inpatient stay somewhere that's not local, it can be driving up costs to just be there to support. So we also really wanted to make sure that we're repatriating those patients back into their community support systems, which is really key to, you know, getting back and active and discharged.
I like the why for that. Good job. Any other questions?
I'd like to jump back to kind of where you started with the bed planning matrix. We've been having a lot of fun in bed planning today with the matrix. Was there any thought behind this? Because think of scaling this to the 29 campuses that we plan for. Any thoughts of embedding this into Epic and the work that we do to automate some of this?
Yeah, I mean, we wanted to start from a foundational layer. Obviously, just implementing technology doesn't resolve solutions. You have to start from the bottom. So that's why we recommended starting with the New Orleans Patient Transfer Center, just as a pilot, because they oversee the most amount of hospitals. So if it's successful there, then we know we can scale that to other transfer centers. But it starts by putting that patient placement council together. You know, the pilots are already making that decision of where patients can go, so they bring that expertise, and then bring those physician leaders as well to kind of just get that clarification of, okay, across our system, which units have those capabilities and where can they go. And we want to start with first the hospitals that New Orleans are overseeing. And so you kind of look at those hospitals, the pilots, the physician leaders, where are these patients going? And then we kind of scale that across the system. And then I think you also mentioned with the Epic. Again, I think that's working with your data analysts as well as your partners over at Epic. We kind of started when we first started researching, looked at the marketplaces. Is there any existing models that you could already implement? And there wasn't. So this would have to be something that was built from scratch. So that's why we recommended data analysts as well as just working with your partners at Epic.
I think to add on a little bit too, that manual process really helps bring everyone to the table. And with that over 2 million we have remaining, that provides, you know, some capital for us to invest in. You know, can we put this in our Epic EHR? Can we possibly build our own AI system for it? You know, they say that's the future, but right now we are with patient flow. That's not quite where it can be. So there's opportunity there for sure.
I know we're almost out of time. Going to the physician in lead of transfers. One of the reasons that we stood it up and we're very intentional about doing it, understanding that it's the largest line item on our budget, is because we have found that physicians, when they are in practice at the bedside, patient facing, do not necessarily have the bandwidth to be able to respond to us on the transfer side immediately. And then beyond that, the pilot being embedded within our patient flow center has been helpful in guiding our nurses at times on the acuity of patients and on appropriateness of transfer to particular facilities. Give me some insight into your thoughts on scaling back on the pilot.
Yeah, absolutely. So, I mean, at the core, it doesn't really change. I mean, just the pilot is not physically located in the facility. So let's say, for example, with the lack of access to the pilot, right? That's the reason we wanted them physically inside the transfer center. So we addressed that through a risk mitigation strategy with, SLAs with the physicians that if a pilot doesn't respond within a certain amount of time, then you can escalate that, right? Maybe to the chief, in some instances to the CMO, just to make sure that you are getting a rapid response. And again, nurses also have that clinical
And
training.
that is time. Sorry.
Thank you guys so much.
Yes, thank you all.
Yes, thank you so much.
Right. Thank you. And as a reminder to the team, the awards placement announcement will take place here at 5:30 p.m. Thank you again.
I was nervous. No, I'm kidding. Oh.
All right, welcome and congratulations once again to making it to the final round of the OSU first year case competition. We are excited to have you here. My name is Tyler Matt. I'll be your host for the presentation. I'll just recap some of the rules. You'll introduce yourselves and we'll get started. All right, so just like the first round, you'll have 15 minutes for your presentation. At the 2-minute mark, I will hold up the sign. And when time is out, I will hold up the stop sign and say time. Then time will be reset. We'll have 10 minutes for Q&A. I'll hand it off to judges. Rules for the signs will be the same as first. All right. Okay. And as a reminder, do not reference your university. That'll be a disqualifying event. So now I ask you to take the time, introduce yourself and your team letter.
Yeah. Good afternoon. I'm Palak, Team S.
Good afternoon. I'm Anna, also Team S.
Good afternoon. I'm Bree, Team S.
Excellent. You may begin when you're ready.
Okay. Last year, 2,249 of the patients who needed our care were transferred somewhere else. 40% of those patients were already accepted by our physicians, and 26% were canceled due to capacity constraints. The issue here is not demand. The issue is how we manage capacity and patient flow. So that is why we want to introduce SAM, an acronym that we created for our strategy of 3 pillars of success. I am Anna.
I'm Bree.
I'm Palak.
So before we dig right into it, let's start with our executive summary. With an investment of $10 million, we address the challenge of having transfer delays due to capacity constraints, which is also driven by throughput challenges. So our SAM strategy will allow us to reach approximately $16 million after year 4, which is equal to an ROI of 160%. We require 9 additional FTEs with the strategy, and we, among many, our impact will be to increase transfer capacity by 10%, and we will reach a system-wide situational awareness so that every team member is on the same page. Oceana's current strengths, among many, are the streamlined operations through the centralized patient flow center, which also allows to reach the defined key metrics for level 1 patient transfers. However, we see that there are some areas of high improvement potentials, such as the level 2 patient timelines, which means 67% of the total transfer volume. We see that those areas mentioned here, they are not translating into full performance yet, and we want to leverage those opportunities. That is why we conducted a SWOT and Ishikawa analysis, and we identified 5 buckets where Oceana is still falling short. Our key findings include that bed and transfer prioritization is currently mainly manual and subjective. Also, our level 2 patients, they are waiting too long for their transfers. Our current capacity is not used in an optimal way, which leads to the case that we are missing out on transfer opportunities. And discharge barriers, as well as post-acute care transition delays, keep our beds longer in the system than they medically have to. And so we create capacity bottlenecks. The consequences of this are critical. Patients do not always receive the right care at the right time they need, and Oceana is missing out on transfer opportunities as well as revenue. So how do we fix this? The solution is not adding more beds. The solution is managing the beds we currently have smarter, faster, and system-wide. So let us introduce SAM, our 3 pillars of success strategy. Each of those 3 pillars addresses the current issues of the patient flow journey in a different way. S stands for Smart Patient Flow Command Center and helps us with the decision making. Who gets the next bed? Who gets the next transfer? A, accelerated throughput and discharge, helps us to free up the beds faster. And M, managed post-acute care transition, addresses the question of how do we move the patients safely out of Oceana system without causing delays. So let's bring this into life. Meet patient Sam, and let's follow his journey through the system. Sam is 67 years old, he's from Mississippi, and he walks into the ED at Hancock Medical Center with symptoms such as progressive shortness of breath and fatigue. Due to Sam's current symptoms, as well as his medical history of chronic diseases, his health levels are currently at 1 out of 3, and he's not well. So Sam is arriving at the facility, his patient movement order is placed in Epic, and the PFC receives the request. Since the Hancock Medical Center does not have a specialty cardiac unit, which Sam requires, we are moving to the left side of this process flow map. So a transfer request is generated, and after the physician accepts it, in Sam's case, our newly implemented automated algorithm ranks the transfer request system-wide, and this system objectively identifies the best bed for Sam across the whole Ochsner system. In Sam's case, the best identified bed is at Jefferson Highway Hospital in New Orleans. So Sam is being transferred, and after destination at Jefferson, he is being diagnosed with congestive heart failure. He receives appropriate inpatient care such as diuretic therapy. And we want to mention that already at the first day of Sam's inpatient admission, he is being assigned a post-acute care team transition navigator who is taking care of everything that follows post-discharge. So as soon as Sam is ready for being discharged, his home health needs back in Mississippi, where he came from, are already prepared for. So Sam is being assisted with transportation. He receives RPM devices such as a scale to monitor his condition from now on. And Sam's health levels are back up at 3 because he received the care he needed at Ochsner, and he's happy with the experience he had at Ochsner. I also want to highlight the step we see here, because with our strategy, we will have an integrated predictive analytics model. So Sam's discharge time is predicted early in the process, and after Sam left, the bed can be assigned swiftly to the next patient.
All right. So what does strategic bed management look like in practice? The answer is having visibility across every bottleneck all at once. So we created a dashboard in Excel with dummy data to demonstrate what that could look like at Ochsner, bringing predictive analytics, real-time data capacity, and automated queuing all under one unified view. These aspects combined form the essence of Pillar 1. And with that answered, the second pillar of SAM asks the next logical question. Once we know the patient is ready to leave the system, how do we make sure that we're prepared for what comes next? And so the second pillar of SAM centers on accelerated throughput and discharge by combining predictive analytics and forecasting tools in order to ensure that the system is redirecting or restructuring when patients enter the system, while also ensuring that key stakeholders have direct visibility into how our scheduling patterns affect every care for every patient downstream. And because our patient SAM's care does not end at discharge, this slide outlines exactly who owns each layer of his care transition, from executive governance down to bedside coordination. The third and final pillar of SAM focuses on managing post-acute discharge placement through a dedicated team of experts known as the post-acute care transition team, or PACT for short. And this right here is a proposed model of what that could look like at Ochsner. By owning the full placement process, our goal for PACT is reducing delayed placement and eliminating avoidable days spent in the hospital. And instead of having every expert work by themselves, we decided to create a PACT workflow that unifies the bedside RN's early flagging, the RN's case manager's clinical validation, the PACT navigator's referral coordination, and the MSW's barrier resolution all into one connected process. This is built around resources already available at Ochsner, like Ochsner's Home Health Network and MyLaurel, to name a few. And so the main goal of PACT is to ensure that every patient like Sam's care moves forward continuously, and that at every single step, there is a clear owner without overburdening any one member of the team. But technology alone does not improve patient flow. Aligning our people, processes, and technology to the organization's visions does. And so when thinking about implementation, we use a strategic management frameworks to remind us that leading change is a process, not an event. And so before SAM scales, we'd recommend a deeper data analysis to sharpen our rifle shot approach to ensure that we're starting with the right people and the right units that are most willing to drive culture change. And with every new idea comes hurdles that must be addressed appropriately to ensure the success of SAM. And so on the right are outlined a few strategies that we identified with the few barriers as well. But this does not reflect a plan to just combat it. This is a plan to build a culture that is committed to adaptability and forward thinking. By celebrating early wins and having clear, visible leadership support, this will create the momentum needed for a successful implementation.
Now, what it takes to execute. To deliver SAM, we require targeted, not excessive investment. We had 9 FTEs at high impact areas like change management, PAC navigators, and analytics. The $10 million investment is strategically allocated to 4 buckets: technology, personnel, training, and remote patient monitoring devices. Importantly, we are not building new systems. We are leveraging existing resources like Epic and enhancing it with predictive analytics and dashboards, and not infrastructure expansion. This is what makes our solution both sustainable and scalable. Now, to the financial impact. This is where SAM truly delivers. By reducing our average length of stay from 0.5 to 1 day, we unlock significant capacity without adding new beds. By reducing the transfer turnaround time from the current 11 hours 48 minutes to less than 7 hours, we increase the transfer capacity by up to 10%. And by recovering the controllable missed transfers, we generate significant incremental net revenue. So altogether, this generates an $800 million incremental net revenue within 4 years, meaning a $16 million incremental net profit, keeping in mind a 2% operating margin. That is 160% return in 4 years. Interestingly, 91.8% of our incremental net revenue is attributed to reducing length of stay, assuming 25% of the freed beds would be converted into admissions and an 85% occupancy rate, meaning this is just a conservative estimate and it has a lot of upside potential. So this is not just an operational improvement, this is a high return strategic investment. So we followed a 3-year structured roadmap for SAM. The first year is working on getting the SAM concept approved for research, solution design, and stakeholder alignment. We engage key users early for their input, essentially using a beta development approach during development, beta testing approach during development. By year 2, we work on getting SAM piloted at high impact areas to validate workflows and document early wins. By year 3, we roll out system-wise and refine operations at the same time. Built into the pilot is a continuous PDSA cycle, plan, do, study, act, to test, evaluate, and optimize performance in real time. So at the end of this operation, SAM is fully integrated into the system. So to measure success, we track KPIs across 3 broad buckets: access, throughput, and system performance. For access, we work on increasing the transfer capacity by 10%, reducing the transfer turnaround time to less than 7 hours, and recovering our controllable missed transfers. For throughput, we work on reducing our average ED boarding time, average avoidable days, and reducing our length of stay, but also work on improving and focusing on improving DBN, that is discharge before noon. And finally, for system performance, we work on increasing our forecast accuracy for predictive analytics, incremental net revenue, but most importantly, staff and patient satisfaction rates. At the end, behind every delayed transfer is a patient like Sam, waiting for the right service,
in the right bed, at the right time,
every time.
Thank you.
All right, thank you so much. All right, the clock has been reset and we will now start the Q&A portion. Judges.
Very nice job, everyone. Thank you.
Thank you.
As you went about your approach and kind of your process for the last few weeks, what were some solutions that you aborted? What did you start to kind of go down a path and decide that wasn't going to work, and why?
That's an interesting question. So we were first going on the track of population health initiatives. So we were also initially planning to get a complex care management team, but kind of reduce the investment in a CCM team, complex care management team, to a packed team. Do you want to take it further?
Yeah, of course. And so we were starting to create ideas that were more so on the tech side without realizing, okay, but technology cannot really do much without having the right people with the right training. And so we spoke to some subject matter experts that reminded us in all their time, they have not seen any idea roll out where technology is at the forefront and it succeeds. And so we kind of flipped our idea on the head and decided, okay, let's just look at what resources are available at the moment at Ochsner and just let's enhance that. Let's use that. What EHR are they using? What capabilities does it have? And then that's where this idea came from.
Yeah. And I think we also kind of narrowed it down. So we started thinking pretty like broadly on how we can leverage the issues of having too high average length of stays, having like throughput challenges. But then we kind of needed to find this link back to the patient flow center. And that's how we narrowed it down to this strategy that we have, like with those 3 pillars, we really address things that is directly linked to the patient flow center and not just like a general Ochsner system population health approach.
There we go. The question I had is really around kind of the FTEs. You know, we have a hard to recruit market at times. And so if, you know, say you posted all 9 positions, do you have a prioritization of what do you think are the most critical resources, human resources that you have that or there's a budget cut and no longer do you have $10 million? How would you prioritize that?
Yeah. So, oops. Yeah. So due to our strategic timeline, the first year really focuses on doing more research, really setting up the systems, bringing in the culture drive, and like focusing on this design part. So we think that in the beginning, it is really important to have process improvement experts and or a change management person who is dedicated to kicking this project off and like being involved from the beginning to ensure success. Later on, when we like really start the rollout, then that's like when we also need the PAC team. So we are kind of like building up from, we're starting with 2 PAC navigators in the pilot year, and then we are building them up in the 3rd year when we start scaling SAM. But in the 1st year, we will not have 9 FTEs. In the 1st year, we will have like 3 to 4 FTEs. Then in the 2nd year, we will add the PAC navigators too, and then like we scale it from there.
And something quickly I'd like to mention, if there ever are budget cuts, specifically for the PAC team, I believe that keeping the PAC navigators and the utilization review coordinators are very essential to making sure that any barriers to discharge placement are not there, because these are the 2 groups that actually confirms the post-acute placement and initiates prior auths, denials, or approvals, which sometimes do delay a patient having to go where they need to go.
Yeah.
Do you think your timeline could be expedited? So say just the healthcare environment's changing constantly, lots of different pressures. And I know the 3-year timeline is what you currently have in there. Like how fast do you think you could do all of this if you were asked to speed up the process?
So I believe since Epic is already like fully integrated into Ochsner system, and Ochsner already went through all of those processes in 2018 before setting up the patient flow center. So we like read that you kind of like visited other command centers or patient flow centers, did the research, went through this process. We are just proposing to kind of do this again because technology involved, because AI is a big topic now, and to see like how can we even like leverage more what we already have. So I think since there is already a very good standard in Ochsner, probably like some of those steps, especially in the 1st year, can be sped up, especially if the executive team is on board. However, before scaling it system-wide, I think it is really important to
keep those pilot phases and to learn from those and to test the predictive analytics model and to test the automated queuing and so on, so that we can like really make sure we learn from this and we improve it from then. But yeah, like we probably would say like we could also like condense it to a 2-year.
Yeah, and on the PAC side, a lot of it leverages on the personnel you guys already own at your center, and so we would just be redefining the scope of their everyday tasks. The only new ones that would be here would maybe be the PAC navigators and the utilization review coordinators, but if they have experience with prior authorizations, SNFs, and home health of that sort, you can possibly find those very same talents already at Ochsner, just giving them a new title and like new training, if that makes sense. Yeah.
And I think the most important timeline is the pilot, because we have read projects of such scale, 70% of them either go over budget or over time. So piloting it early and realizing what challenges that we are facing at a smaller but high impact area, high risk, high needs patients, is easier to improve than rolling it out system wide and then thinking, okay, this is this issue, that's issue. So pilot would be the most time consuming process, but research can be cut down, and yeah.
In one of your slides, you talk about the admission to placement for the PACT workflow. And in step one, you have the RN triggering. Are there specific triggers that have to be met in order for the nurse to say, okay, I'm gonna trigger this process, or is it simply every patient that comes in, the nurse is triggering?
So when it comes to the triggering, I was doing some research on which DRGs are most likely to require post-acute placement. And so, for example, cardiac events, stroke, hip fractures or replacements of any kind, those would be likely the patients that would require like triggers, because we already know what is the pattern when it comes to this type of care. Usually they need more care outside of a hospital than we can provide, and healing works best when you're somewhere more comfortable. And so when it comes to that, that is when the RN usually triggers it. But if a patient is coming in slightly, like it all depends on the acuity of the patient as well. And since we are leveraging experts in their field, I'm confident that they would be able to recognize and work along with this is the best RN. So with the care team, they can decide, okay, based on the trajectory of where this patient is going, they're most likely going to need that second care. And also the PAC navigator works on that from day one to make sure that depending on their insurance, we can get those approvals or denials out the way. And then the utilization coordinator makes sure that if there's a denial, we're already on it. So by the time discharge comes, we already know where this patient's going, what insurance accepts them, and yeah.
Okay, so then based off of conversations you've had with industry leaders in this particular space, get more granular. What is the nurse at the bedside actually looking for? Use a cardiac patient as an example. What are they actually looking for that helps them determine this person I need to trigger?
So I would say more so labs and how like in shape they were when they came, and as their what's it called, as well as the care team, like what is the provider saying, what is their expertise as well, because having the physician's input is important as well to make sure that the RN is doing what the physician is saying, yes, based on these criteria, these health criteria, these labs, and where this patient can go, they most likely will need X, Y, and Z. And one thing I like to note is that even if they have a place ready for them, if they get better and no longer require it, then that service can go to a next patient that was in the same DRG predicament, but they need it and not this one anymore. Yeah.
I'm building on that very quickly because I know we're almost out of time. We will also like take factors into consideration such as SDOH. So if this patient does not have family at home that can take care of this patient from then on, so this will also trigger some kind of acuity need for post-acute care. Or if is there like a chronic history that care was needed like previously? So are there like some factors in the medical record of this patient or social determinants that kind of like push those triggers?
So I know we're out of time, but do you envision the bedside nurse looking for determining the social determinants of health, or do you think that the PAC navigator would do that?
That's should be the medical social worker because that is where their strengths comes in, right? And so we would leverage them to make.
And that is time.
Thank you, guys.
Thank you.
Thank you.
Thank you so much. As a reminder, the awards announcement will take place at 5:30 here in the auditorium. Thank you again.
Thank you.
Let me just keep it here.
Wait.
All right, welcome and congratulations once again on making it to the final round of the OSU first year student case competition. We're excited to have you here. My name is Tyler Matt and I'll be your host for the presentation. We're just going to recap some of the rules. You'll introduce yourself and we'll get started. So just like the first round, we have your 15-minute presentation. At the 2-minute mark, I'll hold up the 2-minute sign. And when time is out, I will hold up the red stop sign and say time. We'll then reset the clock for a 10-minute Q&A session. Same rules apply to the signs. Right, and as a reminder, please do not mention your university name. That will be disqualifying. Right, we'll now look to you to introduce yourself to the judges and your team letter.
My name is Liba Faruqi and I'm from Team D.
Trinity Verduzco, Team D.
I'm Lauren Householder, also Team D.
Excellent. You may begin when you're ready.
Good afternoon, Oshner. Thank you so much for your time today as we present on the road to coordinated care through system alignment. Before we begin, I would love to introduce our team, Team D, again. My name is Trinity Verduzco.
My name is Liba Faruqi.
And I'm Lauren Householder. Transitions of care are some of the most critical moments of healthcare, and I truly didn't know this until I experienced it firsthand myself when my grandma was diagnosed with cancer. She underwent some pretty intensive surgeries, as you can imagine, and I'm sure a lot out there can relate to loved ones going through those surgeries and that journey. And throughout that time, when she was recovering, she was in a lower unit of care and she needed to be transferred back to a higher level. And during this time, instead of spending it with my grandma, I spent it focusing on the clock, wondering how there could be an action plan, but no action seemed to be taken. And my biggest takeaway from this was feeling like there was a lack of urgency, which brings us to the challenge statement that we see it with this case. At Ochsner, you have such a strong patient flow center. They have centralized and it's so impressive. However, the issue is throughput and bed subjective prioritization. So with this, there's delays in discharge we found, and we also think there's a capacity issue that needs to be addressed. And throughout our presentation today, we're excited to address those in our solution, as well as discuss how we came up with our solution, because we believe that is a unique way that we're excited to take you along that journey with us today, go over the implementation of it, and also address some risks as well as finances.
Before we move forward, it's important to ground ourselves in what this health system is created on, its core values. This is ultimately what shapes decisions, behaviors, and how care is delivered. When we ask ourselves a simple question, how is the system functioning today in a way that supports these values, we were better able to identify where they're performing exceedingly well and where there's room to grow. That leads us into our SWOT analysis. Of course, the strengths and weaknesses give us important context, but what we really want to point your attention to are the opportunities and threats. At a higher level, the opportunity isn't adding more resources, it's connecting the resources that Ochsner has, because there are so many resources already put to use. Once we connect those resources, we hope to align teams and use technology to support real-time decision-making. The threats are just important: increasing pressure, patient demand, bed capacity constraints, and embedding technology where it might seem uncomfortable. The real risk, though, is falling behind if we stand still and don't address the coordination of care now.
In our research, we learned about the Toyota way. In the 1950s, Toyota was competing with other car manufacturers for a piece of the market share. However, Toyota didn't have the resources that other car manufacturers did. So instead of trying to add resources where there were none, they looked into the process from end to end, trying to find where there are steps that they could possibly optimize. This shifted our perspective. We instead started to look into where is the delay happening? Where is the disconnect? Because everything is already in place, it's just not working together as efficiently as it could. While technology is incredibly important to our solution, the technology cannot be implemented without the culture evolving to meet that need, which brings us into the framework for our recommendation. Our mindset is a 70-20-10 framework. 70% human factor, 20% automation, and 10% enhanced partnerships. First, the own model, a foundational culture shift. Next, an AI innovation designed to streamline communication at the patient flow center. And lastly, an expansion of one of Ochsner's existing partnerships.
To begin with, the own model.
This, as the solutions follow through, they'll start to build off of one another, but this is where we hope to see the most impact. Ochsner already has an amazing culture. We're not hoping to change that. We're hoping to enhance it by aligning those teams and building on the coordination. We do this by addressing a key issue we found. Departments within a hospital are built in a vertical silo. What we mean by this is emergency departments try and get patients in and out as fast as possible. Inpatient was worried about bed capacity, and care teams are worried about the patient's next step in their journey. Well, a patient's journey is inherently horizontal, meaning they move across multiple departments. When they move across multiple departments, the responsibility also shifts with them. This is where the gap in care takes place. This is what leads to delays, bottlenecks, and often that throughput challenge. So we created the OWN model to solve it. The OWN model stands for Our Patient, Willingness to Innovate, and Navigate the Patient's Journey. Our patient is because when you walk into a hospital, oftentimes when you talk to a doctor, nurse, clinician, they refer to a patient as my patient, when that isn't the case. A patient goes through several different teams before they're discharged, and that's why we want to encourage them to be referred to as our patient and be able to take ownership of them along the way. The way this will work is it'll be facilitated by the Patient Flow Center Throughput Navigator. This is already an employee at the PFC. So they'll facilitate it starting at the New Orleans region and pilot it through workshops and team building opportunities. In these workshops, they'll focus on interdisciplinary case studies and learning how to work in a cross-functional team. Metrics will be scored on an OWN model scorecard, testing psychological safety, how well continuous improvement is happening, but most importantly, encouraging clinicians to step outside of the hospital walls because patient care doesn't stop there, and really stepping into the community and strengthening the partnerships that Ochsner already has, as well as providing community service. It'll be tracked monthly, following with continuous feedback, and then at the end of the year, the OWN model scorecards will be collected. The highest score at the hospital in that region will be incentivized because incentives drive behavior. This slide is pretty simple. What it tells us is if you start at the very first step of the system or assembly line, the people, and make a change to the culture and enhance it, operations will follow. Culture drives strategy. We're not trying to add more complexity to the system. What we're trying to do is align the system to do the things that it was intended to do. Overall, earlier discharges will start to happen. You'll see more predictive bed availability. Everything will align and care will move forward.
Now that we've accounted for the human factor, next is automation. The next piece of our solution is utilizing Epic's new Agent Factory platform, allowing us to streamline and operationalize the PFC workflow. Currently, the road to a PFC transfer looks like this. The significant bottleneck lies between when the PFC begins to work on the request and to when the bed is assigned. On average, this takes about 9 hours, despite the transfer team's best efforts. And this isn't an insignificant amount of time. The longer that a patient is waiting to be transferred, the higher the likelihood it is that they will experience an adverse medical effect. The aim of our solution is to recover those miscontrollable transfers and decrease the time it takes from when the transfer request is sent to the PFC to when the patient is assigned a bed. With the addition of our AI agent, it begins with the transfer request. The agent will evaluate the request based off of a clinical triage tool developed in year 0. Then they will assign an acuity level for the patient. The pilot physician will then review said acuity level and choose whether to approve or deny it. If needed, the agent will also call the referring physician to gather any additional information needed, transferring the phone over to the pilot physician if they are unable to gather and complete the clinical intake. Next, we will be also reducing the amount of time it takes for the PFC to go from the request over to the bed placement. And here is a mock-up of what the Epic interface may look like for our workflow. The drag and drop interface allows for easy development, as well as it is a system that Ochsner is heavily familiar with. Of course, they are integrated with Epic every step of the way, and so we would see the advancement of the technology through this interface.
Now we discuss the first two parts of our solution, cooperation as well as operations. I'm excited to present the final and third piece, which is predictive partners. Now on this slide, it might be familiar partnership, LeanTOS IQ, and it is overwhelming how many leading healthcare organizations utilize LeanTOS because they have overwhelmingly positive results and outcomes. What LeanTOS IQ does is it is an AI-driven platform which manages all this information and makes it easier for physicians, for nurses, and we do not want to implement anything that's going to cause any strain on any physicians or nurses as they already are dealing with so much. We want to make their job easier and not throw new technology and new things their way. We want to implement something that they are familiar with and expand on it to grow the results even further. And through this, it also presents a system-wide visibility of this data. And there's so many cases to select from to support this, as well as Ochsner's current usage using LeanTOS. However, Hendrick is a great example as they saw an increase in their throughput and a decrease in their delays without adding any more beds, which is what we want to do for Ochsner as well. So expanding on LeanTOS, we want to make sure Ochsner is taking advantage fully of this partnership to its full capability and getting to experience those results and better serve their patients as well as physicians and nurses and staff.
Our implementation plan balances speed with sustainability. In year one, we really want to just build on the foundation of what we're trying to create, which is standardizing systems, aligning leaders, and getting the process ready for year two when implementation will start to pick up. This is when those tools will start to get deployed, like the AI agents, the predictive partners will start to get enhanced, and most importantly, the own model scorecards will get deployed. Year three is where we hope to see that culture shift, where accountability and ownership are taken to the next level, and where we hope to see throughputs start to decrease immensely. However, we do know that that plan is not a perfect one-size-fits-all go-to solution without some risk to address as well. The risks that we see might be adoption resistance or data quality. But this is built in with our implementation plan in phases, constant feedback loops, and most importantly, always keeping the human at the forefront. That is with the 70-20-10 built up. We do realize that this plan will have to change as the system changes. It cannot be a stagnant, stay still plan, but move alongside Ochsner.
Here are the 3 financial outcomes that we would like to highlight. First, our plan will be able to generate significant profit by year 3, showing that we have improved throughput as well as reduced bottlenecks. Second, we will also be able to increase our patients that we are seeing, showing that Ochsner is able to continue to be a pillar of excellence in patient care within the community. And finally, we are able to achieve realized returns within the first year, meaning that Ochsner will not have to be undergoing a significant financial risk with this solution. Of course, our financial outcomes cannot be made without the advancement of our KPIs. The decrease in ALOS, the faster discharge, as well as a reduction in the days, as well as a reduction in the patient transfer decline, just to name a few, are all achieved through the system's parts working together like a well-oiled machine, because technological advancements and enhanced partnerships cannot be done without cultural evolving as the foundation.
At the end of the day, Ochsner, your purpose is to serve, heal, lead, educate, and better serve the community and your patients. And through our solution, we believe that we have attached those values into it. And because when people lead, intelligence supports, and data guides, patients move forward, which is the ultimate goal here. From my personal experience, my grandmother, unfortunately, was not transferred before passing away. And a lot of times, that can just be because of the patient's current state of health. But from my experience, I'm left wondering what would have happened if she was transferred. And we want Ochsner to not even have that potential thought cross the patient's mind and create a system that moves efficiently and fast that the community can trust and depend on to serve their patients and their community. Thank you so much for your time. And we would love to clarify any parts of our solution and answer any questions you might have for us today. Thank you.
Thank you. All right, we will now move on to the question and answer portion. The timer is reset. Judges, please take it away.
Thank you all. That was very well done. One kind of question as you were talking about your grandma, it just made me think of like, did you think about how we incorporate our patients into this process or their families, informing them of status changes or bed placements or acceptance at facilities? Just something, did you consider that? Your story really was touching.
Yeah, we did. And Trinity, do you want to talk about the current discharge?
Yeah, when Lauren first actually described her grandmother's story, that's kind of what pushed us towards creating the own model. And also, while evaluating how many solutions you guys did have in place, we kept on doing more research and we kept on hitting walls because you guys have set up so many solutions to stop these transfers from being with these bottlenecks. And what we noticed is actually in your guys' discharge process when we were going over it, what's really great about Ochsner is you do give hourly updates to your patient from a case manager. However, at the very end is when that patient will meet with the doctor and the case manager. Underneath this protocol, I didn't attach it here, but you're given a list of numbers of all the care team that has seen you. This could include the dietitian, doctor, APP, nurse. However, that leaves the responsibility in the patient's hand to make a call to that care team member. It doesn't mean that the patient will actually do it, but they may still have questions. And so with that own model scorecard, it's taking ownership and maybe using cross-functional teams at the very end. If you go to the Emory Health case study, they actually include at the very end of a discharge process, physicians, nurse, pharmacist, social worker, care navigator, all the way at the end. You'll see a 50% decrease in hospital mortality, 10% decrease in patient length of stay, 10% increase in patient satisfaction scores. So all together, really bringing it together for the end at the bringing it together for the patient at the end for clarification and ownership.
Thank you. With your KPIs, did you create any like milestones or goals kind of from how you're going to get, what's that step look like with your implementation plan?
If you want to go to the Gantt chart. And we'll have Lauren explain this one.
Yeah, so as Trinity mentioned, just to clarify, you're asking the continuous checkpoints throughout this?
More on your outcomes. So you kind of have where your KPIs, where you're going to track performance of the 25% reductions, the stay reductions.
Then you can go to the own model scorecard. I think that's where we're going to have the most, it'll be at the top. Oops. Oh. The own model scorecard is where we'll really be able to track the metrics at hand. The one previously, let's see.
Sorry.
That one.
There we go.
Yes. Okay, so again, because it's just a mock-up and every hospital is very different, we don't know what their benchmarks already look like. And so that's where the patient flow center navigator is going to have to work with each individual hospital to find a key benchmark. So discharge rates before noon, because that does take a whole team to be able to move a patient out before noon. The average patient transfer time, even staff improvement suggestions. I mean, in healthcare, you have to have continuous improvement all the time in order to be a pillar of excellence. Psychological safety, how well your team is being tracked, and we'll use the HCHAPS score for that on the care transition satisfaction rate. So it's a bundle of things, and we wanted to make sure to put as many different metrics on there, but make them intentional to where the team has to work together. It can't be just a siloed department.
Thank you for the presentation. Lauren, I'm really sorry to hear about your grandmother. And in fact, that is one of the burning platforms that I have, is trying to avoid that kind of scenario from happening and ensuring that patients are able to get the higher level of care that they require in a timely fashion. And so my question to you guys is actually on the AI enabled operations, and in particular, the solution in Epic. Tell me more about the clinical triage tool and what factors you think are most important to determine when a patient needs to move, how to go about stratifying these patients based off of this tool, and ultimately how it will improve on efficiency.
Sure.
So here is an example of a clinical triage tool that I found for pediatric patients in oncology. And so really we want to be working together heavily with our physicians who work in emergency medicine particularly, so that they are helping to develop this tool and really find like clinical guidelines for how we want to stratify this. Because of course, as like administrative, what we may consider to be urgent is not the same definition as what could be medically urgent. And so during our prototyping phase in our year zero plan, we will be working to create this triage tool and consistently using patient examples to test what the tool is as opposed to what the physician is saying. Constantly testing and making sure that those recommendations are lining up. And of course, we also have the human factor added into it, because even though we have the agent AI giving out this recommendation, it doesn't mean that the pilot physician will have to go with that recommendation and assign that specific acuity level. We have to always bring it back to that human factor, because ultimately using this clinical triage tool and using an agent AI will allow for the physician to have a bit of that mental burnout off of them. The nurses as well in that transfer team too. They are all participating in assessing the patient, assessing the transfer request. And so we want to sort of take off the emotional burden it is to be assigning that acuity level, because it's a lot on just a couple of people. The decisions that you make could be life or death for someone. So if you possibly assign them a lower acuity when it isn't necessarily that and they worsen later, it's a hard situation to deal with. And so we want to at least relieve some of the pressure off of the clinical team to assign these acuity levels and create a standardized tool that can be used at not just one patient flow center, but other patient flow centers as well once we move out of the pilot region.
Can you tell me a little bit more about the lean TOS technology? As best I understand, lean TOS gets its data through Epic. So what can lean TOS do that Epic cannot?
Yes, so lean TOS is already implemented in Ochsner, and through our research that we could see, it was implemented system-wide, but the case study is through the OR and the results that you see in that. And so that has helped increase at Ochsner specifically those like those like the timing blocks. There we go, the blocking time.
The block utilization. Yep. Yep. I'm very familiar. Yep.
And with that, uncertainty of how much that is being implemented into the other departments within your system, we wanted to encourage that to be expanded on. And so what it would look like, essentially, is just another way to kind of enhance off of the current solutions we have. Again, keeping saying it multiple times because it is important. We want to make sure you know that we want to keep people at the forefront of the solution. And then the AI agent, we see this as just a tool to help. If it is already implemented, that is great, but I hope it's not. So this is new and a great idea. But with this Leva's AI agent that she just walked you through, this is just another tool to see more data in a system, centralized data system. Is there a part that I can clarify on that? I think I'm missing part of your question.
No, I think you're getting at it. You're correct. We use it for the ORs. But I do know they have a tool that can help specifically on throughput. I haven't actually seen that piece. Now, this is totally hypothetical, but if you were the CEO and your Ochsner IS team was not super excited about an outside vendor and wanted to create something through Epic, how do you think as a CEO you would leverage the argument, I guess, to go with a tool like this?
Well, we actually did look into the build versus buy. And I mean, it really depends on how fast you want your solution to work. If you build it, you're going to be working with trial and error for a while. You have to get the right kind of data put into that. There's going to be a lot of failures. You're going to have to bounce back from that. The money you're going to put into that to work with Epic, the IT that you're going to have to use to support it. If there's a solution that's already out there in we have case studies where multiple other health systems have worked with them. I mean, you saw the big web, and even you guys yourself are currently using it, where it currently works, and you need that solution now to save so many different people with transfer times. I think that's how you can leverage it, giving them the simple timeline of later and maybe it'll work, or now and we have data that supports it will work.
Additionally, oh, sorry, go ahead.
No, please.
Just a quick jump off of that is that out of the top 25 operating hospital systems in the nation, half are utilizing LETOS IQ.
Yeah, go ahead. I know I'm out of time.
Okay.
Thank
perfect.
you guys very much.
Thank you guys.
All right. Thank you again so much. And as a reminder,
Hello, everyone. This is the part that I've been so excited for this whole planning process. So, very excited to finally announce the winners. But first, I really do want to recognize my planning committee. They've spent so much time planning every detail. And even today, I can't say how proud I am of how we've handled all the different things that have popped up today. Hopefully no one saw any problems that occurred. So I am just so happy that this was a success. And thank you all so much for being here. Just going to flash up. Okay, we have had 22 teams fly in from all over the country. So this next slide is all of the teams that made it here today. Big round of applause to everyone who participated. Beth and Sarah, can you please come up?
The floor is ours.
Mm-hmm.
Okay. Well, hello, everyone. Thank you again for such an incredible opportunity to be able to provide this case and to be able to spend the time with you. I would probably feel compelled to say what I'm about to say anyway, but I actually mean it when I say that we were truly blown away. I think we weren't exactly sure what we were getting into when we committed to this process and to coming here, but you all have impressed the heck out of us. Every single group just did an unbelievable job and made our job very difficult. But what I can say is the future of healthcare is in good hands because you all are already doing some great work. I don't think I would have made it to grad school now knowing what the competition is like. This is incredible. But I hope that you all are very proud. Thank you for all your hard work, your dedication, your research, your professionalism. Just truly incredible. And you made us all very proud. And we are taking some incredible work home to kind of dive in and see what we can do with. So thank you.
I think Beth hit all the points. I mean, I was truly blown away, and I know the entire team was. And they're already taking notes and had their team on the Zoom today on the live stream, watching it and taking notes as well. So I think there's things that we'll truly actually go back and implement, which will make an impact on our patients. And really was impressed with everyone. So thank you all for your hard work on the case. I also want to just make sure we thank our team, the rest of our team that did a lot of the heavy lifting. So Sarah, Amber, and Dr. Quo for really helping pull that case together. And really, thank you.
Okay, So here at the Ohio State Case Competition, we do a Best Presenter award out of each of the preliminary round rooms. So this is from this morning, and this is not necessarily teams that advance to final. So this was decided on by the judges in your prelim rooms. So first, Beth and Sarah, if you guys could come to the center, I'll pull this to take a photo after you. The best presenter out of Jefferson is Trinity Raduzco, Baylor University. Okay. Out of Hancock, Jassim Abdallah, University of Florida. Oh man, okay. Out of Franklin Hamilton, Sierra Robinson, University of South Carolina. Out of Fairfield, Micah Dennis, University of Alabama, Birmingham. Out of the Monroe Room, Audrey Richards, MUSC. Out of the Highland Room, Diana Maline, University of Michigan. Okay, that concludes our Best Presenter Awards. And now for the team awards. Here at Ohio State, we also do award money to fourth place, so very exciting for the finalist teams. In fourth place, Team D, Baylor University. Okay, now for third place. In third place, Team H, University of Alabama at Birmingham. Okay, in second place, Team G, University of Kentucky. And now for first place. Actually, I'll wait, sorry. In first place, Team L, University of Florida. Congratulations, just get checked. This concludes our 2026 case competition. Thank you all so much for attending. We do have one more event this evening just for participants. We're going to be doing a happy hour from 8 to 9:30 at Pins downtown. So we would love to see you guys there. We are not providing transportation, so find that on your own down there. But the whole planning committee will be there, and we're very excited. Have a great evening, everybody, and safe travels back home. Thank you. If you haven't taken photos yet, the photographer is still here with the backdrop for a little bit longer.